works, both of them in Argentina. Jose is in the south of Argentina, and Daniel in Buenos Aires, Jose in Córdoba. So thank you very much, everyone, for joining today. We have a fantastic program, which is all about skeletal dysplasias, going from diagnosis to management, and how to go from ultrasound really to diagnosis. I'm going to share very quickly just very few slides to show you here. This is a program from today. And this was to remind me to thank Daniel and Jose, who have been fantastic ambassadors for us, and distributing really the brand, and connecting with Flaus and Saum, and making sure we have today over 2,500 people online. Please notice there is also a Spanish channel, which is on the other side. You just click the button and the Spanish translation will start in a few minutes. Please save the date. On the 21st of February, we have Gianluigi Pilu speaking to us about cleft lip and palate. Tessa Humphrey will be there. She's an expert in genetics. She will talk to us about what are the genetic conditions we need to consider. Waldo will talk about the first trimester ultrasound, how can that contribute? And Prashant finally will tell us the secret, how he gets those wonderful 3D pictures of the face in order to help us in the management. But today's skeletal dysplasias, you know me, so I'm not going to introduce myself, but I will introduce briefly Sahar. Sahar is a geneticist who works with me at St. George's Hospital. She's a professor in clinical genetics, and her primary interest is in skeletal dysplasias, as well as in lymphedema, dysmorphology, and prenatal diagnosis. She's a fantastic colleague and a brilliant speaker, as you will hear today. Apart from Sahar, I will be speaking, and Simon also will be speaking, respectively, on the second and first trimester. Finally, just one more thank you to GE. GE are sponsoring these events and allows us to provide them to you for free, free of charge. So we thank them very much. And I hand over to Jose and Daniel just to say a quick hello also, and then we will start the program in a few minutes.
Okay, Daniel, you go first.
Buenas tardes a todos en Argentina y en los horarios respectivos del resto del mundo. Gracias, Aris, por hacernos participar a José y a mí. Es un honor estar compartiendo esta presentación con Scan Academy y con estos disertantes de primer nivel como Sara Mansour, Simon Meger y tú en la primera parte. Así que, sin más, espero ansiosamente escuchar también la presentación y bienvenidos a todos los oyentes de Argentina, de Saum, de Flaus y de toda nuestra América Latina. José.
Bueno, también buenas tardes y buenos días para la costa oeste, para Centro y Norteamérica. Y bueno, también es un honor poder participar de esta actividad. Gracias, Ari, por la invitación. Y junto a Saum y Flaus, esta también es parte del comienzo de la actividad docente de la Academia de Diagnóstico Prenatal y Medicina Fetal de Diagnos. Así que, bueno, bienvenidos todos a este webinar.
Fantastic. Thank you so much. Muchas gracias a todos. Rajneesh, please start the video, and I will just tell everyone that you need to give us 30 seconds of your time until the buffering is done, and then you will see, without changing anything, the video, and it's available in English and in Spanish. Thank you so much, and we will take questions at the end.
Hi, very good afternoon in India, and good morning in the part of Europe, and of course very early, very late, good evening in the part of Australia and that region. Now today again we are here together to have one more program by www.scan.academy. You have experienced us since last at least 6 months after the lockdown, and we have tried to give you some good programs across the through the webinar, and we had a really brilliant response. because of the last few programs. Now, today we are going to discuss one of the topic, which is skeletal dysplasia. There are a lot many things associated with skeletal dysplasia. There are quite a new things regarding genetics with the skeletal dysplasia. The diagnosis may be simple, but the problem is to classify it that this particular defect fits to this diagnosis. We can diagnose skeletal dysplasia as a gross at a first go, but putting it to the diagnosis is difficult, and we are going to try to solve these difficulties in today's webinar. I hope we will be able to justify you. We have got three great speakers. One is Aris Papageorgiou. Aris is a dear friend, and Aris is an academician, clinician scientist, and inventor. He divides his time between St. George's Hospital, London, and the University of Oxford, where he runs his global research group as a clinical research director of the Oxford Maternal and Perinatal Health Institute. He is a lead expert in the field of fetal medicine. He is lead in the field of imaging and also intervention, and his research is focused in the area of maternal, fetal, and perinatal health using the diverse methods, including the basic science, clinical epidemiology, trials, and the implementation of the science. He does a lot of work in artificial intelligence nowadays. So you can see him working across for the artificial intelligence too. He is currently runs a large global projects in the low resource setting using the ultrasound biomarkers and the clinical methods to improve the phenotypic and the outcomes. Now, another major interest is the use of artificial intelligence, as I told you, in the pregnancy and imaging. So, and Aris is an academician beyond par, and he has got many research. He has got many peer-reviewed articles. He has written he has got more than 16,000 citations. That is huge, Aris. I must congratulate you for that. And his H index is of 71. That is huge. So I hand over mic to Aris for his first talk on how to diagnose and how to evaluate the skeletal dysplasia in the fetus in the second trimester onwards.
Thank you so much, Prashant, for your kind words, and thanks to all the delegates, 2,500 people who are joining us today from around the world. Thank you for giving up your Sunday to listen to us talk to you about skeletal dysplasias. And I'm going to focus on the second trimester and beyond. And the reason I'm doing that is that the majority of skeletal dysplasias will be discovered, if you like, at that gestation. I'm going to take a problem-based approach and try and see if we can somehow get as close to diagnosis as possible. As Prashant says, the initial impression of this skeleton is not normal is easy, but how do we get to a diagnosis? So let's start by thinking about the standard sonographic examination of the skeleton at our anomaly scan. Please remember to look at the skull contour, the spine, the long bones, and I'd love you to look at each segment of the extremities. It really doesn't need to take long. You don't have to measure every bone in the routine survey, but of course, if you're concerned about a particular skeletal problem, each long bone should be measured. Look at the chest. In terms of the routine measurements of length, we stick to the femur and humerus, position of the feet, and fingers if possible in the routine scan. Standard examination consists of visualizing the long bones, each segment of the four extremities, and make sure that when you look at the femur, you don't just look at the presence of the femur, but you look at the different elements of it, including the diaphysis, metaphysis, epiphysis, and the distal ossification centers. Cross-section through the leg like this will exclude talipes with a great degree of accuracy. Make sure you see tibia, fibula, radius, and ulna, as well as the standard measurements of the humerus and femur. And of course, if you see the segments of the hands and the toes, that is always a great thing. I know it's not always possible in a routine examination, so I think if there's no concerns at all, and the baby has the hand closed, just being able to count the fingers is probably enough. You don't need to see the individual segments. But if you do have a suspicion of a skeletal problem and you're doing a formal skeletal evaluation, then really you need to wait, take your time in order to see all the individual fingers and toes. We plot, of course, the length of the different measurements. And one of the things you can do is to relate the length of the femur to the biparietal diameter or to the head circumference as a sort of assessment of the relative size of the long bones. Although most of the time it's not necessary because you have the standard measures of the different biometric variables. Evaluating the fetal thorax. So here I've got pictures in the transverse and the coronal and in the sagittal view. And what you can see here is, first of all, in that transverse view, it's in fact a four-chamber view, but it's not as magnified as the four-chamber view. So you see the whole chest. You can see that the heart taking up about a third of the thorax there, and the ribs nicely surrounding the thorax rather than sort of squeezing it. And I'll show you some pictures later of how that can look different in different skeletal dysplasias. If you look at that coronal view, you can see a nice normal and smooth outward bending chest wall. And in the sagittal view people often worry, and it's it can be a little bit more difficult in the sagittal view because you often have this little ridge here where you see the abdomen sticking out more than the chest. Remember, the baby's breathing as well, so sometimes you have what looks like an exaggerated, and maybe the sagittal view may not necessarily be always the best in order to look for a small chest. I think the coronal view is really valuable, as is the transverse view, and with experience you will also get a really good impression from the sagittal view. What I always say in all my talks is please don't wait until you have a really difficult case where you're not sure what's going on to, for the first time, look at the chest wall in the sagittal or in the coronal view. Make a habit when you have a little bit of extra time in your clinic, in a normal fetus, to look at the normal anatomy, and by recognizing lots of normal anatomy, you will then, when you come across a difficult case, get an immediate impression by pattern recognition of what the abnormality might be. So take advantage of your routine patients in terms of getting used to what is normal. Of course, the thoracic circumference can also be measured, so in terms of objectively assessing the size. So that's the sort of standard exam that you're going to do for your skeletal assessment. And I'm now going to start talking a little bit about skeletal dysplasias. And people get a bit scared by skeletal dysplasias. And I'm going to try, well, all three speakers, we're going to try to take take away a little bit the worry when you see an abnormal skeleton. And I think part of the reason that people are a bit worried about skeletal dysplasia is just because it's such a heterogeneous group of disorders. I mean, think about the difference between severe end of the spectrum like thanatophoric dysplasia on the one hand, very, very early gestation with very abnormal bones, and something like achondroplasia on the other end of the spectrum. Or think about things like osteogenesis imperfecta, where you might have fractures, or achondrogenesis, where you have undermineralization. And the two can be easily confused sometimes, and the sort of large number of syndromes and large number of names can seem like a barrier to understanding. And also, I think the classification, if you open a textbook of skeletal dysplasias, it looks really complicated. So what I'm going to do instead of that complicated scheme of chondrodysplasias and osteodysplasias, etc., I'm going to take just a problem-based approach. And I'm going to start with a problem-based approach, which is that you do a scan, usually in mid-gestation or perhaps an early growth scan, and you find that the femur length is short. Because I think that's the most common reason and the most common way we encounter skeletal dysplasia. You've done your measurements, head circumference, abdominal circumference are within the normal range, femur length is really short. So what do you do? And what I'm going to try and do is guide you through the different ways to assess that. So the first thing to do is to see what is the gestation where I'm first noticing this. So look back at your previous scans. And the question is this something that started early on in pregnancy, say 11 or 12 weeks? Is it something that I've seen at around 20 weeks? Or is it a late presentation? So do I have a very normal 20-week scan? And it's the first time I'm seeing these short, long bones is at, say, 28 or 30 weeks. And that is an important difference. So that early gestational age versus the late gestational age of onset. And of course, we don't always have serial scans for all women. A woman may present for the first time late in pregnancy. But look back as much as you can at any previous examinations. So let's start with the earlier ones, and they fall sort of into two categories. One's where the bone modeling is largely normal and where the bone modeling is not. So if you look at earlier onset, say around 20 weeks, and you see that the rest of the bones, actually the bones themselves look normal. In other words, they look normally mineralized. They are straight bones. And if the abnormality is unilateral, so just on one side with a normal contralateral femur in this case, then what you have is a focal hyperplasia syndrome. Here I talk about focal femoral hyperplasia because we started our presentation or our problem, if you like, with a short femur, but you can have focal hyperplasia of other long bones as well. If it's bilateral and the bone modeling is completely normal, please think of the possibility, if it's a very mild abnormality and it's sort of just on the borderline, whether this may be constitutional, but also think of the possibility of growth restriction. And I think really importantly here, I believe strongly that uterine artery Doppler should actually be part of the skeletal survey, and I'll make sure that I put that front and center in various cases that we'll be presenting today. So this was a study we did here at St. George's where we looked at isolated short femurs with normal bone modeling. So these were babies referred to us with a short femur less than the third centile, and the bones were otherwise looked normal. And all these women had had previous screening for trisomy 21 because they're part of a sort of routine cohort of women who have first trimester scanning. And in this group of 80 women, we found 0 chromosomal abnormalities. And that's because they had been previously screened. So remember, generally speaking, an isolated short femur is actually a pretty poor marker for Down syndrome. It has a likelihood ratio of pretty much 1. So not a strong marker. And if there are no other features of Down syndrome, then it's not a useful marker. So in this study, we then followed up these babies, and what we found was actually that about half of them, just under half of them, actually ended up with fetal growth restriction, and a short femur was the first sign in these babies of FGR. So these are the two groups. Let me just go back. So we have half of them pretty much remaining unexplained, and the other half becoming fetal growth restricted. There were also some false positive cases where when we remeasured the femurs, actually they remained within the normal range throughout the rest of the pregnancy. So if you look here, 90% of those that subsequently got growth restriction had abnormal uterine artery Doppler. So here I'm talking about uterine artery Doppler not as a screening test, as we normally think about uterine Doppler as a screening test for preeclampsia, but as an aid to help us to reach a diagnosis. So you've seen a baby, the limbs are short. If the uterine arteries are very abnormal, then growth restriction is high on your list of differential diagnosis. If the uterine Dopplers are very normal, then it is very unlikely that this is a placental problem, and you need to think more again about your skeletal problems. And notice that the growth-restricted babies eventually had a birth weight centile of a very low birth weight centile, but even the unexplained group had a birth weight centile of 5, so the 5th centile. So these were small babies. And of course, there's a continuum. So we defined growth restriction as needing delivery before 37 weeks, but it is likely that even the unexplained babies contained within them a significant number of babies with SGA, if you like. So that's the sort of normal bone modeling. So if the bone modeling is normal, you can generally be reasonably reassured, but of course there are some genetic conditions that we might want to consider, such as shocks that Saha will cover in her talk. Let's then look at babies with abnormal bone modeling. And abnormal bone modeling can be a variety of things. So just have a look at these images. Here's a femur, and you can see that right in the middle of that femur is an acute angle, so suggesting perhaps a fracture or some sort of bendiness. Be careful at trying to distinguish bendy bones from fractured bones. This is another case here. You can just see that the soft tissues seem almost too large for the bones. Here, this is much more convincing of a fracture, isn't it? Where you have a real angle right in the middle of the shaft of that bone. So if you think then of abnormal bone modeling, think about the 4 different categories that I want you to think about. The first are bowed or fractured bones. The second are very hypomineralized bones. Third, we're going to look for polydactyly in these babies, and there are some polydactyly syndromes, short rib polydactyly syndromes, which we'll cover. And finally, look at the head, the shape and size of the head, to look for any cases of microcephaly. Here we have thanatophoric dysplasia. So thanatophoric dysplasia, which comes in 2 types. Type 1, where you have these very abnormal bowed femurs that you can see, the sort of classic, the classic telephone receiver type of femurs. And type 2, where actually you have straight femurs, as you can see there on that X-ray, but you have the very classic existence of a clover leaf skull. So the 2 different types of thanatophoric dysplasia. Here, type 1, where you have these bowed bones, type 2, where you have straight bones. And the femur length, really from very early on in gestation, you can see there in the blue line, very, very small compared to what the normal range should be. So easy to recognize from an early gestational age, but often not picked up until 20 weeks. And Simon will cover a little bit about what the first trimester scan can show us. Here, type 2 thanatophoric dysplasia with that very characteristic clover leaf shape skull. And for those of you who don't have English so good, this is clover. It's the plant, the trefoil. This is where the name comes from. The limbs in thanatophoric dysplasia, you can see that the limbs are sort of stubby, and you have lots of soft tissue that surrounds these small bones with ossification centers, as you can see there, really not being normal. You can see that the bones are all universally very, very small, and you have this redundant soft tissue that surrounds the baby, and the redundant soft tissue also tips into fetal hydrops, which you can see in thanatophoric dysplasia, as you can see it also in a number of other conditions, such as achondrogenesis, achondroplasia when it is homozygous, and the short rib polydactyly syndromes, which we'll look at in a little bit. Here, looking at the chest, I'm going to just show you the normal chest there on the left, and this is the chest in thanatophoric dysplasia. And again, you can see that redundant soft tissue around the ribs. Can you see that? And that very abnormal thorax to abdomen ratio, so a very large abdomen there compared to the thorax if you at the same magnification. But I don't even know that you necessarily need that when you look at that picture of the thorax with the ribs really compressing the chest. You feel like the ribs are squeezing on the lungs and the heart. You know, that relative cardiomegaly and that very redundant soft tissue. And then when you go into the coronal plane, you can see that instead of having that nice rounded shape of the ribs that you normally expect, you have the ribs squeezing inwards. It's been described as a champagne cork. I'm not sure that that's necessarily a very good description. Here we have a sort of parasagittal plane. So if you go just off the sagittal plane, in the normal scenario, you can see these nice, lovely normal ribs on that left picture coming up to the front. And here on the in the thanatophoric case, very shortened ribs. And once more, if you just turn your transducer there, you can see that also in the axial plane. So I think there's lots and lots of clues of this shortening of the ribs, which of course is not just relevant here for thanatophoric dysplasia, but for other dysplasias as well. The second very severe early onset condition that you see often as early as 11 and 12 weeks is achondrogenesis, which is a group of severe disorders, and they affect cartilage and bone development. They're really characterized by a really small body and short limbs and a number of other skeletal abnormalities. It's a lethal condition, usually before birth or soon after birth due to respiratory failure. You can see the very characteristic finding here of a very demineralized skull. So there's hardly any bone in that skull, micromelia, or in other words, short, long bones, and very characteristically, this demineralized spine. The femur length, again, similar to thanatophoric dysplasia, very, very small indeed. And it can be difficult to tell the two conditions apart, but there are some sonographic findings that may give you the clues. And one of them is this finding in the head here from the second trimester scan of caput membranaceum. In other words, the skull is made of a membrane rather than of bone. Short trunk with thoracic hyperplasia, and that very characteristic finding of absent vertebral bodies. So to show you this picture of the caput membranaceum, just this very soft skull, and one of the things you can often see first is you get this impression that you can see the structures in the brain extremely clearly, and that's just because there's no reflection of the ultrasound signal away from the skull. Now, like thanatophoric dysplasias, there are two types of achondrogenesis. So it's, you can remember that both of them have two types. Type 1, which is really characterized by the partial or complete lack of ossification of the calvarium and the spine. And the other one, type 2, which has a more variable degree of calcification of the spine. And the reason this is potentially important is that type 1 tends to be a recessive, whereas type 2 is autosomal dominant, of course, usually de novo in nature, well, always de novo in nature. Here, then we continue with some more pictures. I don't know what you think here. You can see these two bones in the forearm. I think I could probably convince you that both of them have a strange angulation and a little break right in the middle. And these are actually cases of osteogenesis imperfecta. Now, when you first do the scan, you sort of put your probe on and, you just get the impression that something's not quite right with the formation of the skull there. And then as you move down to the limbs, you can see these really very, very short limbs. Important in your skeletal survey as much as possible to look at all the different structures, all the different bones, and here moving then to the lower limbs, as you could see there. And you can see that the lower limbs are really very short. So what is this condition now? You're thinking, could it be achondrogenesis, but you've got a normally mineralized spine there? Could it be campomelic dysplasia? Well, you've got normal scapulae there that we were just seeing. So scapula is normal, is one of the signs of campomelic dysplasia, the absence of the scapulae. And in fact, I can tell you that this, despite the fact that these bones look just really short and maybe even telephone receiver-ish, actually was a case of osteogenesis imperfecta type 2. And the severity and of the fractures inside the inside the long bones, these many fractures mean that ultimately what happens is the bones just get very short. But there you can see a really acutely angled bone, and you can see that there on these images and also on 3D. So this is type 2 osteogenesis imperfecta. There's lots of types of osteogenesis imperfecta. Saha will correct me, I'm sure, but I think at the last time I looked, there were 8 types. And type 1 is the mildest and the most common type, so half of OIs roughly are type 1, and that's the ones that's associated with mild bone fragility and relatively few fractures. But the one that we see in pregnancy is usually the type 2, which is an abnormality of the collagen gene. So it's really an extremely severe type, and this is also the type that will cause death due to respiratory and cardiac complications. So here you can see rib fractures. You can use a maximum amplitude as well in 3D or the VOI in order to look at the bones, and that can be helpful. And one of the characteristic and dangerous things, or one of the things that causes the severe problems in OI, apart from the long bones, obviously, is the rib fractures as well, causing this severe inward turned ribs, as you can see there on that axial view on the right. Here we've got a case of osteogenesis imperfecta type 3, which is much milder phenotype, so bowing of the long bones, and can be difficult to distinguish from bowing fractures, and perhaps Saha can comment on that later in the discussion as well, as to how much over the years, how much we've perhaps improved, or maybe not, in telling apart bowing of long bones from actual fractures. Because if a fracture heals, you don't see that sharp angle anymore, and the bone gradually gets a more bowed appearance. Bowing of the femora and tibia is also common in campomelic dysplasia. Here, all the long bones are very short, and this is where I want you to look during your skeletal survey at the scapulas. Again, look at normal scapula, familiarize yourself what it looks like. It's easy. You just skim the surface of the baby with your ultrasound transducer, like when you examine the spine in a coronal plane. And often the genitalia are also abnormal in appearance, so that's another clue for campomelic dysplasia that I want you to look at. So that's taking care of that little box there of these bowed and fractured bones. Carrying on then, hypermineralized bones and the lethal form of hypophosphatasia, which is an autosomal recessive condition. We have really this extreme undermineralization of the long bones, and this is an X-ray of a neonate. And the fetuses may also have fractures, but actually it's usually the low mineralization that is so characteristic on the ultrasound images. And this is a case here in the late first trimester. Oh, this was a video but won't play, I'm sorry. But I think even just on that still image, you can see that there's very little, if any, calcification of the bones in that baby. You can see it almost looks all made of soft tissue. I'm going to move on to polydactyly and the importance of assessing the fingers in the baby, because when you have polydactyly, you need to consider a number of conditions. Please look to see if the polydactyly appears preaxial or postaxial, and this here is a case of thoracic hypoplasia together with polydactyly in a short rib polydactyly syndrome. And here we have the preaxial or postaxial on 3D. There's 3 conditions that you need to think about. Short rib polydactyly syndrome itself, which is kind of a continuum, and again, Saha may explain to us a little bit more about how these 3 conditions interact between each other. So we have SRPS, Ellis van Creveld syndrome, and Jones syndrome, or asphyxiating thoracic dysplasia, as it's also known. So all these three have short ribs, abnormal bone structures, and limb and polydactyly. In Jones syndrome, we have much milder limb shortening, and Ellis van Creveld tends to have the polydactyly as preaxial rather than postaxial. So this is a sort of differential diagnosis between these three conditions. So finishing up with the bone modeling before 24 weeks, just before moving on to the next slot, bowing may be difficult to differentiate from fractures. Both suggest diagnosis of achondrogenesis, thanatophoric dysplasia, campomelic dysplasia, or OI. If you have definitive hypermineralization, think of hypophosphatasia, but OI, of course, is also hypermineralized. And polydactyly is characteristic of short-rib polydactyly, especially at very early gestations. Later, think of Ellis van Creveld and Jones. Just very quickly then, for the late presenting skeletal dysplasias. Now, obviously, we've covered the polydactyly conditions already, so I'm just going to concentrate on achondroplasia. And again, please make uterine artery Doppler part of your survey, because when you see short, long bones, even in the third trimester, early third trimester, say at 28 weeks, could this be growth restriction? And if you have completely normal uterine Dopplers, as in this case here, then it's unlikely that placental insufficiency is the most likely thing. And you need to think about achondroplasia, which of course is the most common skeletal dysplasia. So gradual fall off of the femur length, often not evident until 24 weeks and beyond. And this is the same case here at 19 weeks and at 32 weeks. And you can see how the profile changes. So easy not to find any features of achondroplasia at your routine 20-week scan. These are the conditions that will only be detected in the third trimester. At 20 weeks, you may see very mild, sort of the bones being within the normal range, but on the milder end of normal, but it's not a useful marker as such. And in the third trimester, you see this mild shortening and bowing of the femurs, relatively large head. You can see here the saddle nose and also the characteristic trident hand in this case. A femur to foot ratio was recommended earlier. I don't think it's a hugely useful marker because there's so much overlap. If you want one very useful marker, is this one that was described from our unit here, which is looking at the proximal, so the hip end of the angle between the diaphysis and the metaphysis. So in the panel A there, you can see the bone, just angle your transducer, so you have that those two diaphysis and metaphysis seen clearly. And then what you can do is measure the angle between them. All ultrasound machines have a simple angle measurement tool. And normally, the normal angle is about 100 degrees. Here, what you can see in the normals, about 100, 109 degrees. SGA, because they are normal, have a very similar angle. But in achondroplasia, the femoral angle is much more open, as you can see there. So this is quite a sensitive marker for achondroplasia. But as FGFR3 testing is becoming more widely available, perhaps such testing takes over our ultrasonographic markers, and I'm sure Saha will be able to comment to that. SCDC, an important but fortunately rare condition characterized by short, long bones, and the clue here in the third trimester is micrognathia. So I hope I've given you an overview of what to do when you see skeletal shortening. Please look for associated abnormalities. Do your careful skeletal survey, looking at all the bones, including fingers and toes, scapulars, looking for associated features such as genital abnormalities and campomelic dysplasia, micrognathia and SCDC. Look at the fetus in a lot of detail. Please include uteroplacental Doppler, uterine artery Doppler. If Dopplers are completely normal, then consider that you may be dealing where the skeletal dysplasia is more likely, even if everything else looks normal. In achondroplasia, again, uterine artery Doppler is normal. Look for that head to femur disproportion and look for that proximal diaphysis metaphysis angle. Testing for achondroplasia, is possible now with maternal cell-free DNA, and I'm not going to say anything more because I know that Saha is going to discuss all about in clinical exomes and the importance of not just chromosomes and karyotype, but actually doing an exome of the entire genome in these cases. So then in skeletal shortening after 24 weeks, we've discussed it before 24 weeks already. So in the third trimester, as a summary, this may be due to achondroplasia, classical dwarfism. SCDC is an alternative diagnosis, but I have to say that it's not often made prenatally because the ultrasound features are subtle, and the clue is that micrognathia. Polydactyly, we've covered already in the previous scheme, but that is suggestive of Jones or Ellison-Crayfield, and both are characterized by a degree of thoracic hyperplasia. So I hope that with this sort of general scheme, putting it all together, you won't freak out next time you see a skeletal dysplasia or you see abnormal bones, but just calm down, be systematic, look at those different pointers that we've talked about, and gradually you will get closer to a diagnosis, which of course you must always remember will only be possible to completely verify by genetic testing or postnatal assessment. And that's where Saha comes in with her talk. So I'm going to hand over to you, Saha. Well, let me introduce Saha, since Prashant, I hope it's okay for me to introduce Saha since we work so closely together. It's really such a pleasure to invite Saha. I'm really honored that she was able to do it from her holiday in Wales this weekend. Saha, thank you so much for being by my side again during a difficult time, because Saha is always by my side if there's any difficulties in our diagnosis with skeletal dysplasias. We work in the same department at St. George's Hospital. Saha is a clinical geneticist, did her master's in genetics at the Institute of Child Health in London. She's a medical doctor and a pediatrician, and subsequently subspecialized in the field of clinical genetics. Skeletal dysplasias and prenatal diagnosis of skeletal dysplasias is one of her major interests, both in the clinic and in research. Saha is a very accomplished academic with over 200 publications. She also has a real interest in lymphedema, but that's for another day, I think, Saha. But I know that she's particularly proud of the National Centre at St. George's here, which we have, which is the National Lymphedema Clinic, where people from really all over the UK come to this one clinic that Saha looks after and founded a few years ago now. I might not say how many years ago it is. Saha, thank you so much for joining us today and talking to us about the genetic aspects of what we've already started discussing.
Thank you very much for inviting me. It's a pleasure to talk to you all. Can you see the slides?
Yes, please.
And you can hear me clearly. That's good. Good. Yes, I work closely with Aris. We have a clinic every Wednesday, and they bring the potentially genetic cases on a Wednesday so that we can scan them together and discuss the possible diagnoses and prognosis. And I do have an interest in skeletal dysplasia, so I'm very happy to talk to you about our experience. So there are more than 460 types of skeletal dysplasia, but only a small proportion of them present antenatally, so we don't need to know about all of them. And it's a very, very well characterized group. The genetic cause is known in more than 80% of these cases. So it's a relatively easy group to finally make a diagnosis, not antenatally, but subsequently. And it can be inherited in many single gene mechanisms, dominant, recessive, and occasionally X-linked. But please take away the message that this is rarely chromosomal. So the array CGH is of very little value when you have a skeletal dysplasia. If you think you've got a baby with a skeletal dysplasia, the detailed chromosome analysis is very rarely helpful. So I said, how much genetics do the audience know? And Iris said, well, it's variable. So I'm going to start really basic, and forgive me if it's too basic, but I'm sure for some of you it might be helpful. Imagine that all you participants are, each of you is one book in a library, and your genetic makeup is in these books. So you take one book, one person, one fetus from the library and have a look. And each chapter in the book represents the chromosomes. So the chromosomes are packages of genes or words. So each chapter is a chromosome. And the array CGH, the detailed chromosome analysis, simply looks to see if there are some pages missing. It doesn't read the words. It simply looks to see if there's pages missing or too many pages. So it's the level of resolution is at the chromosome level. You cannot see single gene disorders. In a single gene disorder, you have a spelling mistake just in one word, and it changes the meaning of that word. So apparently this book sold millions of copies because of a change in letter from life to wife. And so you have to ask for different tests to look for single gene disorders. In the UK, we routinely do detailed chromosome analysis. I know it's different in some countries, but that is not a useful test for skeletal dysplasia. If you know what you're dealing with, you know exactly which gene it is, you would ask for Sanger sequencing, and that is a very accurate sequence of just one gene. In some conditions, such as achondroplasia and thanatophoric dysplasia, you can look at cell-free DNA in the maternal circulation by doing non-invasive prenatal diagnosis. So you take blood from the mother and you can detect fetal mutations just in a few conditions. So it's a very specific test. We're getting better. We can now do a panel of genes that looks at between 2 and 30 genes, looking for the cause. If you know what ballpark, you know it's a skeletal dysplasia, but we don't know which one, you can do a gene panel. But we're getting even better now. In the UK, we're now able to do rapid fetal exome sequencing, which means looking at all the clinical genes, the genes that can cause disease. In one go, we get a result within 2 weeks. It's a really good test, and it is becoming more and more useful. So that is exome sequencing, and within the next year we will have whole genome sequencing where they look at all of the DNA. Now, as you can imagine, the exomes, which is the coding genes, only account for less than 2% of the DNA. So if you can imagine how much data you're going to get from whole genome sequencing, you can see that it becomes increasingly difficult to interpret that information. So they focus, if you say this fetus has a lethal skeletal dysplasia or it has a skeletal dysplasia, you can focus on the specific genes associated with that phenotype or presentation. And we have these panel apps now for the genome sequencing, so you can see that there are 584 genes that can cause bone problems. So you don't need to look at all the DNA. The problem with exome or genome sequencing, both of them are problematic, but genome sequencing even more so, is that we are all individual. We all have variants that nobody else has. We are all special. So there are lots of variants of uncertain significance. They've never been seen before, but we're not sure they cause the condition. So if the more genes you look at, the more variants of unknown significance you will find. And this has become my full-time job now, looking at these VUSes or VUSes, trying to determine if the variant that you found in the genetic makeup is the cause of the problem. Was it pathogenic or is it benign? And sometimes it's just uncertain. So it is critical, absolutely critical, to get as much information about the fetus as you possibly can. It might not be during the pregnancy, it might be at post-mortem or when the baby is born, but it is really important to look at the X-rays in particular and to look at the genetic results to see if they match. Otherwise, you're going to make mistakes. So moving on to the skeletal dysplasias, that's just a background about the genetic testing. Lethal skeletal dysplasias I've broken down into how to think about making a diagnosis in the lethal disorders, those presenting with what look like fractures, and as Aris covered, the non-lethal presentation of short long bones. I'm going to highlight some common pitfalls. I have made them all, and highlight which genetic testing is best in each scenario. So we initially take a history of the pregnancy. Are there any maternal illnesses, bleeds? Have they been any maternal medication? Is it twins? Because as Aris highlighted, intrauterine growth retardation is a common cause of short long bones, particularly the femurs. What was the results of the biochemistry and the nuchal translucency in the first trimester? Is this actually representing trisomy 21, particularly with short femurs? If the risk was very low, then the risk of trisomy 21 is very low. Is there any short stature in the family or any other problems in the family? Have there been previous pregnancy losses? Are the parents short? Are the parents related by blood because of the increased risk of recessive disorders? Parental age, particularly paternal age. Paternal age is associated with achondroplasia and thanatophoric dysplasia, and also Apert syndrome. So it gives you, if you've got an elderly father, the husband is of increased age, you may think about those three conditions. And it often helps to look at the parent's height and proportion. Now, you're always scanning, the lady's lying down. It might be difficult to see that actually she's not very tall either. So it's useful to watch her as she comes into the room or leaves the room and look at the partner. Why bother? I mean, really, do you need to know exactly why? What the diagnosis is? Well, I think you do, because it helps you to predict prognosis, and I'll give you a few examples in this talk. It helps you to look for associations and complications. Will they have intellectual disability? Will they get orthopedic problems? Some of these conditions associated with hearing loss or visual problems. It's important for the couple because they may be sad about this pregnancy, but the most critical question is this going to happen again? So if you've got an accurate diagnosis, you can accurately tell them their risk of this happening again and enable testing at an earlier stage in future pregnancies. So I think it is really important to be precise as you can about the diagnosis. And because the genetic cause is known now in so many skeletal dysplasias, this is actually the best group for making an accurate diagnosis eventually. If you see short long bones in the 11 to 14 week scan, it is probably a lethal skeletal dysplasia as a general rule. If you see them in the fetal anomaly scan at 20 weeks, it's probably a non-lethal. If you see them in the third trimester, it's probably placental insufficiency or intrauterine growth retardation as a general rule. However, as you all know, there is significant overlap, so you can't be categorical about these definitions. So you do need to think about whether it could still be a skeletal dysplasia in the third trimester or whether it is still lethal even if presenting later. So, lethal disorders. Aris has beautifully outlined the findings with lethal disorders. You can see the growth tails off from a very early gestation. In this fetus, as he described it, there's the bowed femora, very short femora in a telephone receiver configuration. There are short, stubby fingers, brachydactyly, and a saddle nose and a flat facial profile. So this is not too difficult to suggest that this is, and also the thoracic dystrophy, the very small chest, shows that it's probably a lethal dysplasia. So it's not difficult to see that that case was thanatophoric type 1. And as Aris pointed out, there is also type 2. Again, they have severe micromelia, very short long bones, but the femora are straight. So you might not think of thanatophoric, but if you see this cloverleaf skull, we've got the same slide here, you need to think of type 2 thanatophoric. What Aris didn't tell you, which I'm surprised about, is thanatophoric means death-loving. So this is truly a lethal skeletal dysplasia and a very severe condition. This is a baby after post-mortem with thanatophoric. You can see what Aris described as the excessive tissue, because the tissue is normal, but the bones are very short. You can see the flattened nasal bridge, the frontal bossing, the relative macrocephaly, the severe micromelia, and sometimes these babies are hydropic. And the x-rays show very short ribs. You can see thin vertebral bodies, micromelia with a curving of the humeri, as well as the telephone receiver femora and the trident acetabulum and the pelvis, these little pointed spurs in the pelvis. This is not a difficult diagnosis to make when you have an x-ray like this. I know some of these women will opt for a surgical termination, so we can make it on a genetic basis. But if they do have a medical termination, or if they have if the baby's born and subsequently dies, the most critical thing is to get the x-ray so that you can make this relatively easy diagnosis. The thanatophoric dysplasia is due always to a new mutation. Because it's lethal, it's never inherited. So it's a new mutation in the fibroblast growth factor receptor gene 3, FGFR3. I know most of you have heard of this, and it is associated with increased paternal age. This is a really interesting gene. Like many of the genes, it causes a variety of problems with varying severity. So some of the mutations cause thanatophoric dysplasia, a lethal skeletal dysplasia. There is a hotspot here in the transmembrane domain. 2 mutations account for 98% of achondroplasia. Incredibly easy genetic test to do. So this is achondroplasia. And there is a milder form of skeletal dysplasia called hypochondroplasia, where they have very few problems. They're a bit taller than achondroplasia. And again, it's due to the same gene. So the same gene can cause a spectrum of conditions. If you have a child with a fetus with thanatophoric dysplasia, the recurrence risk, because it's a lethal, so it's never inherited, the recurrence risk is really, really low. I've looked at the literature, there's no convincing recurrence. So we state a 1 in 1,000 recurrence risk. So rather than doing an invasive test to check for the subsequent pregnancies, we actually do non-invasive prenatal diagnosis looking for the specific thanatophoric mutation found in the previous pregnancy. And this provides huge reassurance to the couple. Even though you probably see it at the 11-week scan, we can do a non-invasive test as early as 10 weeks. So a useful test to do. So there are a few take-home messages from this talk. And one of them is that if you see a lethal skeletal dysplasia, you only really need to think of 3 main conditions, and they account for 1/3 of all these cases. So if you guessed one of these, you would have a reasonable chance of being correct. The 3 most common lethal skeletal dysplasias are thanatophoric dysplasia, osteogenesis imperfecta type 2, which Aris has covered, and achondrogenesis type 2. There are lots and lots of others, but these are the top 3. Achondrogenesis type 2, as Aris said, the clue is the very soft skull. and also the unossified spines, and they may have a small chin if you can possibly see it. They're often hydropic as well. So you may possibly be able to make a specific diagnosis. The type 2 are always due to new dominant mutations in collagen 2, so the recurrence risk is really, really low. But you need to be careful because in type 1A and 1B, it's recessive, so the recurrence risk is 1 in 4. And it's difficult to make that call during the pregnancy. The type 1B may be confused with osteogenesis imperfecta type 2 because you may see fractures. So again, this is something you need to make eventually, but perhaps not during the pregnancy. Osteogenesis imperfecta type 2, you see decreased bone mineralization, angulation and bowing of the limbs, fractures, but the bones may look squat, crumpled like accordions. So you might not recognize that they're fractures, but they look abnormal. So we have missed some type 2 OI initially, but made the diagnosis subsequently. There are 3 types actually of type 2 osteogenesis imperfecta, but it's not, they all vary in severity. So type 2C is the most severe. With such a soft skull, you often don't see the skull. Type 2A and then type 2B, but they're all can be caused by the same genes. So it's not essential to differentiate. So if you have a fetus that looks like it has a lethal skeletal dysplasia because the chest is small, the long bones are very short. There was a beautiful paper but many years ago showing that you have a 90% chance of getting it right. So you're very, very good at detecting whether a condition is lethal or non-lethal. But if you're talking about the specific diagnosis, exactly what is it? Actually, we're not so very good antenatally. Our accuracy is only 50%. And it is important because some of these are recessive and some of them are new dominant and very, very unlikely to happen again. So hugely helpful information. So you're very good at picking up lethality, but not so good at saying what it is. Common pitfalls. The only condition that we have seen 2 or 3 times, and we've called it a lethal skeletal dysplasia because of the thoracic dystrophy, the very short ribs, is this condition. So very short, long bones, very short ribs, and this baby had an atrioventricular septal defect, AVSD, and this was a clue here. And if you look carefully, these babies may also have polydactyly. So they are often mistaken for short rib polydactyly, but actually this is a non-lethal condition called Ellis-Van Creveld syndrome. It's a recessive condition. You get polydactyly, you get dysplastic nails, you get neonatal teeth in a baby, multiple frenulae in the lips. Not that you'd see any of these. You occasionally get a cleft lip, and they have a short chest and short long bones. It's not lethal and they have normal intelligence, but they often are very short and have orthopedic problems. So it's not a benign condition, but it's non-lethal. And this can present as in the pregnancy as a lethal skeletal dysplasia. So be careful. The polydactyly is a good clue for the diagnosis. It can occur in the short rib polydactyly syndromes. There are 4 of them. They are all recessive. They are all lethal. But the differential is this Ellis-Van Creveld that I've just described, and Jearns asphyxiating thoracic dystrophy. Again, some of these babies can survive. Some die in the neonatal period, but the prognosis is different to the short rib polydactyly because some of them survive. So be aware, these 2 conditions, Ellis-Van Creveld and Jearns, may present as looking like a lethal skeletal dysplasia. So in summary of the lethal skeletal dysplasias, you have a very high chance of getting it right, but watch out for EVC and Jearns. And it is always helpful to either get a post-mortem or x-rays if you possibly can before organising genetic testing, because if you think it's thanatophoric, it's a very cheap, easy, quick test. If it's one of the more rare lethal dysplasias, you'll probably need to do a whole exome sequencing. And whatever you do, please store either DNA from the chorionic villus sample or from the post-mortem. I know some of these are surgical terminations, so please try and store some tissue so that we have a chance of making a diagnosis in these babies for the sake of the parents. So the next scenario is when you think you're seeing fractures. And again, there are lots of pitfalls. I've fallen in all of them. What looks like a fracture isn't always a fracture. So here is a case. It's got some angulation of the femur, and it looks like it's broken. Actually, the mineralization of the skull is not too bad here. You may see some bowing of the femur, or here you can see a fracture of the femur. It may be osteogenesis type 1 or 4, which I'll explain to you. In osteogenesis imperfecta, the long bones are usually on the 5th centile. So they're not very short, but they may be a little bit short. So you may see these fractures. And so you can see a slightly short femoral length. And this is OI type 3. This is a baby with OI type 3. It's a very severe but non-lethal form of osteogenesis imperfecta. You can see multiple fractures with callus formation here. You can see thin ribs. Sometimes you can see fractures in the ribs, and the bone density is reduced. These kids have huge problems with fractures. The treatment is improving. They are now given regular bisphosphonates, which has reduced the number of fractures, but it's a very nasty condition. Aris touched on the different types. He's right, there are 8 types, but the most common 4 are these 4, and they're in the wrong order in my brain. I always remember it as the wrong order. Type 1 is the mild, non-lethal type that you probably wouldn't see antenatally. Type 2 is the very severe perinatal lethal type that both Aris and I have described. Type 3 you may see antenatally with fractures. These often do survive, but it's very severe. And type 4 is a moderate, so it goes in the wrong order. And you may pick up some of these antenatally. Collagen 1, mutations in the collagen 1A1 or A2 gene are the cause in the majority, but there are some recessive forms. The genetic testing is enormously helpful to look at recurrence risk. So if you have a baby with a collagen 1 mutation causing osteogenesis imperfecta, but the parents are not affected, the recurrence risk in this group is really high. It's 5 to 7%. Considering the parents are not affected and it's a new dominant mutation, the recurrence risk is high, and that's because one of the parents sometimes carries a mutation in more than one egg or sperm, so you have gonadal mosaicism. So it's very different to the thanatophoric or achondroplasia recurrence risk, much higher recurrence risk. So you may then offer prenatal testing in the next pregnancy. NIPD is an option, but it's not a good option because nearly all of them have the unique mutations, and you have to make a bespoke, non-invasive prenatal diagnosis. It's very expensive and actually probably not a good option. It's probably better to offer a CVS in subsequent pregnancies. It always used to be thought that if you saw a fracture antenatally, then it was always type 2 or type 3 osteogenesis imperfecta, but I've seen type 1 and type 4 presenting just with 1 or maybe 2 fractures antenatally. So be careful, it might not be as severe as you think, unless, of course, there are signs of lethality. So I hear that I'm not alone in making this mistake. This is a fetus, and it looks very much as though there is fractures of the long bones, the normal mineralization of the skull, and curvature of the long bones. This is a couple. I told them that the baby was very highly to have osteogenesis imperfecta type 3. It wasn't the lethal form. She presented at 20 weeks with these angulated long bones. And so I was pretty certain, but she did not want any invasive testing. She insisted on continuing with the pregnancy without any further testing, which of course we agreed with. And this baby was born and was absolutely fine, never had any further fractures. She was pretty angry. She wrote to the Sun newspaper, and we were featured in the Sun for telling them that the baby had brittle bone disease. And this condition was benign perinatal hyperphosphatasia. So it looks like osteogenesis imperfecta antenatally, and it's been published. And I have never fallen for this again, because it is a really common and easy mistake to make. So it's important because this form of hyperphosphatasia, benign perinatal, they do really well. They have teeth problems, they may have joint problems later, but they have normal intelligence, they're pretty good. It's usually dominant, this form. But there are also recessive forms which can benefit from enzyme treatment, which you can start at birth. And we now in the UK have a license to use this enzyme. So even for the more severe forms of hyperphosphatasia, you can really make a difference to their quality of life. So absolutely critical to make this diagnosis so you can treat them, you can give them a correct prognosis based on the genetic testing. So a very common pitfall, and I think people from all over the world have fallen for this one. There are many types of hyperphosphatasia. I've seen many, many adults with this condition. There is a difference between the perinatal lethal ones that Aris showed earlier, where there is very little mineralization of any of the bones. You might just see one or two vertebral bodies. There is the perinatal benign, where the mineralization is actually normal looking, but it looks as though they have fractures. I'm not sure if they're real fractures or just angulation. You can have it presenting in the infant or the child or even adulthood, and some forms just affect the teeth. And this is the clue would be to measure the parental alkaline phosphatase levels, because it's usually inherited. But as you know, the alkaline phosphatase level in a pregnant woman is not very reliable, so we don't rely on, it's not very useful. So genetic testing in this scenario is enormously helpful. And the gene for this condition is the alkaline phosphatase gene, and it can be dominant or recessive. So the more severe forms are recessive, and the milder forms are dominant. Actually, the perinatal benign can also be dominant as well as recessive. This is another angulated femur. Only the femurs are affected, bilateral angulated femurs. I thought this was osteogenesis imperfecta type 3. I told the parents, they continued with the pregnancy, worried that the baby would have a lifetime of fractures. But actually, this is a femoral hyperplasia, and the baby actually had this femoral facies syndrome, or femoral hyperplasia with unusual facies. It's associated with small chin, so perhaps you should look at the chin to see if it's small, and a cleft palate, which I know is much, much more difficult to pick up. And then it only affects the femora, so the lower limbs are very short, but the upper limbs and trunk are normal. The genetics for this condition is not known. There is an association with maternal diabetes, and I've seen it with gestational diabetes as well. And then again, this is a baby with an angulation of the tibia with a short fibula. It looks like a fracture, but actually this represents a baby with campomelic dysplasia. So look at the genitalia. The 3/4 of the boys have sex reversal or ambiguous genitalia. I've got Aris on several times to look at the scapulae, because often the scapulae are either very small or absent. He's got very good at looking at scapulae now, and that's a good clue. And again, the genetic testing would help. So I think for a non-lethal condition where it looks like they've got fractures, I think a fetal exome is the way forward now that it's available to some of us. So in the lethal forms, we've described osteogenesis imperfecta, shows lots of fractures, poorly mineralized skull, but you can usually see the bones. In the lethal hypophosphatasia, you might not see very many bones. There may be bones that look missing. They're very thin. They're not short, squat, and crumpled like the OI type 2. So these are the lethal forms. In the non-lethal forms, if you look down the list, actually, they look identical. It's really, really difficult to tell whether a baby has an OI type 3 or hypophosphatasia, unless, of course, you have a family history of one or the other. So on the scans alone, you will not know. So not all angulated long bones are fractures. Hypophosphatasia may resemble type 3 osteogenesis imperfecta. The treatment management is different. The inheritance is different. And so this is an ideal group for doing a rapid fetal exome or a skeletal dysplasia gene panel to inform the management of these cases. And finally, I'm going to talk about the non-lethal skeletal dysplasias. These are not usually diagnosed in the first trimester. They're usually in the second or third trimester, and they usually present, as Aris has outlined, with short, long bones. The most common diagnoses are achondroplasia, hypochondroplasia, which occasionally presents antenatally, but not often. SHOX deficiency, which we have a big interest in, and I'll outline. SEDC, and as Aris said, the most common cause by far is intrauterine growth retardation. So look at the baby's Dopplers and abdominal circumference for clues of IUGR. This is a baby showing a tail off of the femur length from 24 weeks and a relatively big head, macrocephaly. You can see here the depressed nasal bridge, the saddle nose, the frontal bossing. So this is a typical profile. And these are the trident hands. There's a gap between the second and third fingers, and the fingers are a little short. So this represents achondroplasia. This test that has been developed at St. George's, well, it's been developed in a number of places, but published by our group at St. George's, with the widening of the femoral proximal diaphysis metaphysis angle, has proved to be really, really helpful to us, particularly because this is not detected till the third trimester. So measuring this angle gives us a good clue. And I thought you'd be interested to see this X-ray of a newborn baby with achondroplasia, showing what the radiologists describe as ice cream cone proximal femora. And you can see the lucency in the proximal femora because of the sloping metaphysis, which you can see antenatally with this increased angle. So it represents exactly what you're seeing here on the neonatal X-rays. The other clue here is the trident acetabulum and other features that will give us the clue. So I just thought you'd be interested to see why you're seeing this increased angle. So it's an autosomal dominant condition, so it can be inherited, but most cases are new mistakes in the gene, 80%. So in 80%, you will not have a family history. Of course, if you have a family history, the diagnosis is very simple to make. Genetic testing is really cheap and easy. There are only 2 mutations in the FGFR3 gene that account for 98%. Incredibly easy test to do. And the big thing to remember, please remember that if you see short, long bones before 24 weeks, it's probably not achondroplasia. They really do not become short until after 24 weeks. Often the women have been referred because of polyhydramnios. The baby seems large for dates, so they go for a further scan, and it's detected that the short, long bones are the long bones are shorter. This is a clinical picture of this trident hand with the splaying of the fingers and a gap between the second and third, and also the third and fourth fingers with short fingers. And of course, you're all familiar with this condition, which is classic dwarfism. So the clues, the father may be of increased age. The short long bones present after 24 weeks. There is a big head, relative macrocephaly. You may get it from the other ultrasound findings that we've outlined. This is a case we had recently presenting with short femurs in the third trimester with a relatively big head. You can see that the femoral angle is normal. And I did do a rapid fetal exome here because I was a little bit worried about the discrepancy between the head circumference and the short femurs. And this is a baby with hypochondroplasia, so a mild form of FGFR3 mutation, and they are a bit taller than achondroplasia, but you do not get that increased angle at the proximal femur. Testing is easy. You can do an invasive, but we're always reluctant to do an invasive in the third trimester. We don't want to induce premature labor. So NIPD, non-invasive prenatal diagnosis, is a really, really good test. If you think the baby may have achondroplasia, just take maternal blood, and this is a highly reliable test, particularly if the mother, it's not useful if the mother has achondroplasia, but if the parents are not affected, it's a really, really useful test. We've used it many times. And again, if the parents are not affected, the recurrence risk is extremely small. It's probably in the region of 1 in 1,000. Oh, and because the recurrence risk is really small, we also offer non-invasive prenatal diagnosis for future pregnancies because, again, it gives them enough the reassurance that the new baby is not affected. We have published fairly recently about SHOX deficiency. SHOX is a gene on the tip of the short arm of the X chromosome. It is the reason that Turner's syndrome girls are short. So if you have a mistake in this gene, or if it's missing, then you can present with a short stature, not dwarfism. They're usually about 4'9" to 5'2", 5'1". They may present in the second trimester at the 20-week anomaly scan, or the third trimester with short long bones, but the bone modeling is normal, the mineralization is normal, there's no other abnormalities. And the big clue here in the majority of cases is to look at the parents. If the parents have short stature with a bit of shortening of the forearm particularly, or a Madelung deformity, which is like a collis fracture, it looks like a collis fracture in the females, then you know that this is likely to be SHOX deficiency. And here we've published in just a couple of years ago 6 families with SHOX deficiency. You can see here this gentleman has short stature. He's actually got rhizomelic shortening. Here the mother had relatively short limbs, particularly mesomelic, which is the forearm. And she has a Madelung deformity. And this in all these cases, it presented at 20 weeks with slightly shortened femora. The reason it's important is because it's a completely benign condition. They have short stature, no other problems really. And the condition is licensed for treatment with growth hormone. So if you make this diagnosis, you can, if the parents wish, offer growth hormone to improve the height, the final height. More rarely, less frequently, you can have a child with a fetus presenting at 20-week scan with short long bones with spondyloepiphyseal dysplasia congenita. These babies often have a small chin, so the clue here is a small chin. So 20-week scan, short long bones, small chin. And these are usually due to collagen II mutations as dominant condition. Very famous actor Warwick Davis, who's helped us a lot in the skeletal dysplasia group, has SEDC. His wife has achondroplasia. So you can see that they're quite often shorter than achondroplasia. So it is a true dwarfism, but not the classic form. They have other problems with cleft palate, myopia, and they get really bad orthopedic problems because of the epiphysis, spondyloepiphyseal, so it affects the spine and the epiphysis of the long bones. So joint pain and hip problems are a major problem, but they have normal intelligence. And the hands are normal. So if you see that normal hands on the scan, that might help you. And finally, intrauterine growth retardation by far is the most common cause of short long bones in the third trimester. And you may also get hypospadias and ambiguous genitalia if it's a placental insufficiency. And the clues here are that the femurs are just a bit short, they're not very short. There is normal modeling and mineralization of the bones. There may be evidence of placental insufficiency with abnormal Dopplers. Aris showed that that's common. We've also seen people who had illnesses during the first trimester, and it's caused a sort of disproportionate growth retardation. So the Dopplers are normal, but actually it's probably still, one of them had severe chickenpox. She was on ITU, and the baby's Dopplers were normal, but the long bones were short. Low PAP-A levels at the first trimester screening may help you to determine that it's placental. And the big clue is that the abdominal circumference in these babies is often small, or even if the head circumference is spared. So testing during the pregnancy for skeletal dysplasia, the tools we have, if you think this is thanatophoric achondroplasia or hypochondroplasia, cell-free DNA, NIPD is enormously helpful, highly accurate, very reliable. If not, if you don't think it's one of those three conditions, then you probably need to do a CVS or an amnio or even a fetal blood sample if it's later in the pregnancy. If you've got a very strong idea what it is, for example, if the couple have had a previous baby with a skeletal dysplasia, you can just opt for a single genetic test, just looking at the one gene that you know is likely to be the cause. However, if you have no idea what the cause of the bone problem is, then we're very, very lucky at in the UK to now have rapid fetal trio clinical exomes, and the hit rate for skeletal dysplasia is higher in this group than any other group. But be careful, read the reports really carefully, because it's not unusual now to get variants of uncertain significance, and you need to be careful in interpreting these results. Chromosomes of RACGH are pretty useless. They're not usually helpful in this scenario. Please think about testing after the pregnancy. If there's a termination or intrauterine death, please store DNA. If it's not a surgical termination, please offer a post-mortem. If they don't want a post-mortem, at least x-rays. Most of these can be diagnosed on the x-rays. If the baby's born, then we as clinical geneticists get involved. We will do a skeletal survey. We will decide on which testing to do. If we know what it is, we'll do a single gene. If we don't know what it is, we'll do an exome, or in the future, we'll do a genome. But I do warn them that sometimes it takes years for us to finally make a diagnosis, and there's still some where we do not have a diagnosis. And I haven't really discussed this, but please remember that if women have a skeletal dysplasia, of course, you need to think about their management and their mode of delivery. They may get respiratory problems with a normal grown baby. So you do need to refer them probably to maternal medicine. So finally, the key points, just a few take-home messages. If you forget everything I've said, the only things to remember are, if you've got a lethal, please try and work out if the baby has a lethal or non-lethal skeletal dysplasia, because that will help the couple to make a decision. And thanatophoric dysplasia, achondrogenesis, and osteogenesis type 2 are the very most common. Remember that not all fractures, not all bones that look fractures are fractures. So think about the differential, and I think exomes are useful in this scenario in a non-lethal form of skeletal dysplasia. And not all short long bones are skeletal dysplasias, so intrauterine growth retardation can present with disproportionate short long bones in the third trimester. Try and store DNA from the baby, either from the CVS or the tissue from a termination or IUD, because it is really helpful for the couple to be accurate about the diagnosis. And be aware when you read the reports, particularly of the exomes or even genomes in some countries, because of the risk of these variants of unknown significance. They do put them in the report. It's easy to think it's the cause, but be careful of VUSs. And ARACGH is not helpful in this group. There are some references that you may like to read. There is a nosology. Actually, there is a much more recent, I'm sorry, I haven't updated. There's a 2018 nosology and classification of skeletal disorders that groups them mainly under the underlying genetic cause now in families of conditions. Thank you very much for listening to me. This is a picture showing that actually they're not telling us what they look like or what their diagnosis is, which I thought was appropriate in this group. Thank you.
Thank you.
Thank you, Saha. That was so good. Prashant, is it okay to take just a couple of questions? Because just to have a little mini break, if you like, before we go into the next talk, just because there's some very specific sort of genetic questions that we could ask Saha, if that's all right.
I've already pointed out 6 questions at the moment. So
can I just start with one very quickly, just because it's directly relevant to the last point that Saha made, which is a question from Egypt. And the question is about from Amira about how do we store fetal tissue for genetic analysis? So you've had a termination or whatever. What's the best way, Saha, technically, if you like, to store? What would you store?
Yeah. So, do you mean during the pregnancy or after the pregnancy?
After the pregnancy, probably.
Pregnancy.
Yeah.
So a little bit of the placenta, you send it, don't put it in formalin, make sure it's not in formalin, put it either in saline or dry and send it to your genetics lab, the same lab that do the chromosomes, the same lab that do the ARACGH. They will be able to extract DNA from that tissue, and you just write in big letters, please store, until further investigations have been done on the baby. So it's not difficult. The big thing is not to put it in formalin. Put it in formalin, it's yours. It's useless, completely useless. Yeah.
Can I ask a couple of questions to you straight? How much accuracy will you diagnose the skeletal dysplasia, and which are the conditions which you will be able to diagnose skeletal dysplasia by cell-free fetal DNA?
So that's increasing. At the moment, we can definitely do achondroplasia, thanatophoric dysplasia, Apert's disease, Apert syndrome. We can do some other conditions like Noonan syndrome as well, but we can also do things like osteogenesis imperfecta. But the difference in those groups is in the achondroplasia and thanatophoric, there's just 1 or 2 mutations. So you can develop the test and it's useful for the whole country or world. But in osteogenesis imperfecta, each baby has a different mutation, so you have to make a bespoke test. So it's very expensive. It takes several weeks, much less useful. So any condition where you get a recurrent mutation, the NIPD is relatively easy to develop. Okay.
Which are the gene panel which you have said that you have developed a gene panel for skeletal dysplasia?
Yeah.
Now, which specific gene panel you have incorporated in that panel?
So I showed a slide. It had a link to the panel app. If you click on that link from the slide or copy that URL, it has 400 more genes on there. So there is the UK have developed these gene panels, and there is one for skeletal dysplasias, but it's got rather a lot of genes. They're not all relevant for prenatal, so it might be helpful, Aris, actually, to develop a prenatal skeletal dysplasia panel, because then you'll get less VUSs in that. Yeah.
Yeah. What we can do is maybe we can take a screenshot of that slide and put it up at the end for anyone to see if that's all right. Prashant, there's a few questions, Prashant, from, obviously we've got a worldwide audience here, and a few people have asked if are there any commercially available tests for these skeletal dysplasias? Are these sort of you know, obviously within the UK NHS, it's a different thing. But if are you aware, Saha or Simon or Prashant, about commercially available tests for skeletal dysplasia panels for NIPT?
In fact, if the list is there, which Sarah or which if we can put it here a slide, any lab can create the menu. It's about any genetic lab can create the same menu, whatever Dr. Sarah can suggest us. So we can ask our genetic lab to create exactly the same menu, and every lab across the globe, they can develop the same menu, and we can the same system.
Aris, there are lots of commercial platforms. I don't use them because I work in the NHS, but there are a lot of them that provide similar gene panels. Yes, I'm not sure about NIPD. I think but certainly for exome sequencing.
In India, still NIPT we are not doing for skeletal dysplasias and self-repeated DNA yet. Yeah. One quick question from the audience was association of cardiac defect with skeletal dysplasia. That's for you, Aris. And can we have a quick checklist in the second trimester? These are the two questions which are relevant to your talk, Aris.
So I think a sort of a quick checklist. So for your routine anatomy scan was really those first 4 or 5 slides that I showed. So look at, measure routine measurement of femoral and humeral length as part of the routine scan. If they're within the normal range and you've seen the standard views of the long bones, the fingers and toes, if that's normal, then the likelihood of a severe skeletal dysplasia is essentially, very, very low. Obviously, with the caveat that, as Saha also explained, that achondroplasia, hypochondroplasia will not be evident until the 3rd trimester. But certainly in terms of excluding those severe early skeletal problems, they will be gone if you do just those routine scans. And that, that's distinct from the detailed skeletal survey when you suspect that there is a problem. That's obviously a much more extensive examination. And I've seen a question about the scapula and the clavicles and whether we save images. Yes, I think if you're suspecting that there's a skeletal dysplasia, you're doing a skeletal survey, save your images because they may be useful for your discussion with your geneticist. If it's a routine scan, no, I don't save images of clavicles and scapulas routinely, just the long bones.
Now, one very basic question: how to diagnose skeletal dysplasia? Is it at 5th centile, 1st centile, 3rd -3 standard deviation or -5 standard deviation? It's occasionally a kind of disagreement in the diagnosis if between two people, even for the diagnosis of skeletal dysplasia. In reality, there is no dispute. Either the cardiothoracic ratio or the thoracoabdominal ratios are defined. But the diagnosis of skeletal dysplasia, can you throw some light, Aris, as well as Simon?
I think Saha's slide with the individual measurements was really nice, which showed that, there isn't a cutoff where, you can say definitely this is normal or definitely this is abnormal in the same way that there isn't for SGA or any other condition. So the further you are away from the normal range, the more the risk is of an underlying problem, and the closer you are to average, the lower the risk is. In general terms, in clinical practice, postnatally as well, one uses 2 standard deviations, which is a 2.7th centile. In practice, most viewpoint systems and fetal chart systems have the 5th percentile there. And I think the crucial element is if it's a measurement that's very near the bottom of the range, if you like, in terms of the length, what you would want to do is follow that fetus up to see if there's a further deviation or whether the growth is in fact maintained along that centile. I don't know, Simon, if you have any other comment to that.
No, Iris, you've answered the question perfectly.
And we have developed a chart, special charts for clinically relevant charts. For all long bones, we have developed 5th centile. We have also developed 1 centile. So we have those charts. So the moment it goes below 1 centile, there are more chances of skeletal dysplasias. So it will because at the moment the charts, all the charts which are available either in the machine, they don't show the standard deviations. So if I want to calculate -3 standard deviation or -4 standard deviation, it's a problem. So that's the reason we have developed those charts, which for all long bones, and also the head circumference, is it below 1 centile or it is above 1 centile? Because it will change the dimensions and it will change the prognosis. Now,
Prashant, can I just picked up one question that I just wanted to discuss with Saha, which I think we've both kind of said about type 1 achondroplasia. Type 1 achondrogenesis and type 2 OI. You know, both have really short extremities. Both might, look, the fractures may be crumpled, so they can be quite difficult to distinguish. So Dr. Shantosh is asking from India, how can I differentiate these two? I don't know if you have any in particular clues, Saha, but I think I would have thought that the spine, the mineralization of the spine might be the best clue for that.
Yes, I agree. I think we often look at the vertebral bodies, don't we, to see if they're present. If they're absent, we're pointing towards achondrogenesis type 1, and if they're present, it's probably OI type 2. The skull can be thin in both, hypermineralized in both, and the other clue is in type 2 OI. The long bones are often short and squat and crumpled because of the fractures, whereas in achondrogenesis they may look fractured, but they're very thin. So, but we can get it wrong. We've got it wrong before, so that's why it's really important to try and get to the bottom of it eventually. Perhaps not in the pregnancy, but it can be tricky.
Shall we carry on with Simon, do you think? And we can have more questions at the end? What do you think, Prashant?
Yeah, we can have more questions. There are more than 40 questions which are after scrutiny. So we have taken few of them, and I think we will discuss after Simon's talk. But before that, can I request Dr. Sarah Menor to send that link to us so that we can display it on the slide later on at the end of this?
I'll put it in chat now.
Yeah, you can put it on chat. So we can display it later on.
This is the panel app that we're using in the UK with a list of genes. It's not specific to prenatal, so it's for all skeletal dysplasias. I don't know that we've got one for prenatal, but I can find out, and maybe if it doesn't exist, we could perhaps create one, Aris. I think it would be good to have a prenatal gene selection app panel. Yeah. So the link's there now.
Yeah, thank you very much, Aris and Saha. Let us move to Simon for his talk on the first trimester diagnosis. And I'm actually really, I would say I'm lucky to have Simon as my friend, and I'm a fan of Simon Mark. Let me tell you that way. Simon is a consultant sonologist at perinatal department, Mercy Hospital. He's from Melbourne. He's a fantastic and phenomenal teacher. With the passion he teaches. That's the amazing thing. And he has got unbelievable collections of ultrasound images, videos, especially for the first trimester, because he follows NIPT in the first trimester and he does scans before NIPT. So the pre-NIPT scan, what he called is a pre-NIPT scan, he is phenomenal. He has got huge clinic. He has got more than 50 people working at his clinic and moving that way. Over to you, Simon. We are hearing you since on the Scan.Academy since long, and I wish we continue doing this great work for across the globe for academic fist for all of them and all of us also. We also learn a lot of things from these webinars. Over to you, Simon.
Thanks very much, Prashant, for that your kind words. And also I would have to start by saying that they are probably the two best lectures that I've heard in my 27 years of practice covering the difficult topic of skeletal dysplasia. So I take my hat off to both Sahar and to Iris. So I'm going to talk about something slightly different in the first trimester, and there are some aspects about first trimester screening and diagnosis that are a little bit different to mid-third trimester and postnatal screening and diagnosis. And I'd like to cover those. And on the talk, I've divided into the following sections. An introduction covering detection rates, global versus focal. And then I'll proceed into the focal, because this is really the strength of the first trimester. And in the focal, we'll cover digital anomalies, limb reduction defects, talipes, fetal akinesia syndromes, spinal anomalies, and then I'll finish up with some summary and comments. Let me start my watch. So if you look at it from the first trimester perspective, I guess one of the first things that Sahar mentioned in her opening sentence in skeletal dysplasia is that while there are so many, many of these do not present prenatally. In fact, the majority present postnatally, and that's a very important point, that we can't have a high expectation that we're going to pick all cases of skeletal dysplasias. And we are aware that many of them are manifest in the third trimester of pregnancy, but some aren't, and are in fact manifest in the early years after birth or early years of life. In fact, the further you go back in pregnancy, the more difficult it gets. And in a sense, in the first trimester, we certainly struggle with these skeletal dysplasias that Sahar and Iris have covered so eloquently. Where our strength lies is more in the lethal, in a small group of the lethal, but more in the focal, because the proportion of fluid to limbs is much greater than the second and third trimester. And therefore, in terms of picking up focal anomalies, we certainly have got our improving detection rates. The other important point from a first trimester perspective is that remember that for many of these skeletal anomalies, many of them are either stillborn or will die within the first year of life or succumb in the first or second trimester of pregnancy. Those ones that present with severe shortening of the long bones with fetal edema and never get to see Sahar. And many of these are aneuploids. So aneuploid doesn't become is of no great significance in the second and third trimester onwards, but in the first trimester, it does play a role. So in terms of diagnosis of short limbs, it's usually in combination with multiple anomalies, and therefore it doesn't get the spotlight of being a skeletal dysplasia. It gets the spotlight of being an omphalocele or a facial cleft with short long bones. So you would say to me, Simon, well, look, listen, what is the point in trying to screen in the first trimester for skeletal anomalies? Because you can't really see the skeleton. And I'd say, well, actually, you can. The skeleton, as you know, is formed at that stage, but you say, yeah, the ossification or description of the shape of the bones, the morphology. Well, I'd say, actually, that is well described. And if you look at the skeleton and pay attention to it, I think we can improve in our detection rate, particularly for the lethal skeletal anomalies. So if you look at it, the bones ossify throughout pregnancy. And in a sense, this becomes difficult for us because that ossification is in its early stages, and phenotypic expression or characterization or trying to work out whether you run for a single gene or multiple gene panel is always going to be limited in the first trimester because it's hard to phenotype, particularly the non-lethal skeletal dysplasias. So yes, we are limited. Also, there are charts not only just for the long bones, but for the clavicles, the mandible, the chest size, and the orbital diameters, also renal size. These are all available for 12 to 13 weeks of gestation. So if you are suspicious, you can get to a certain point in trying to phenotype a features, particularly if you're looking at throwing a skeletal panel in the mix after a chorion biopsy. I think probably the single most important thing, if I put an X through all that and say there's one single thing that I would want you to remember, is to take a femur length at 12 to 13 weeks of gestation. And that should actually be part of your biometry. If you look at the ISUO guidelines, after you get a CRL, the point where you're getting to 12, 13 weeks of gestation, you need to include BPD, head circumference, femur length. And if you're an enthusiast, you can throw in humerus length. And when you look at taking a femur length tomorrow morning, if you go to work at, say, 12, or let's say 13 weeks of gestation, your femur should be pretty close to a centimeter. So if you're getting a femur is around about 5 millimeters, 4 millimeters, 3 millimeters, you're looking at a skeletal dysplasia. But when you actually, if you've experienced in first trimester, it's not actually the measurement that catches your eye first. It's those plump limbs we talk about, and they look plump because the bone looks short in comparison to the size of the soft tissue of the limb. And that's how they catch us. And I'll show you examples of that in a second. From the point of view, I won't not touch on genetics because this has been covered so nicely, but the 4 groups are there. And for us, I will add in, make mention about CMA in the first trimester becomes relevant. But it's either NIPD, CMA, where you know what there's a pre-existing history of skeletal palate. If you don't know, a trio exome sequencing. I'll say no more. In terms of the published literature, you say, well, what is there in terms of screening and diagnosis of skeletal anomalies in the first trimester of pregnancy? Well, thanatophoric dwarfism clearly stands out because it's one of the most lethal. And looking at that, the BPD to femur length ratio of less than 3 at 13 weeks will bring you home. But I say that, look, I know that will, but for most of these, as you actually subjectively look at them, the grossly edematous, the long bones, you don't even need to measure them. You can see they're severe micromelia. But if you want to put a specific measurement on, this is a good one to do, to look at a BPD to femur length ratio. After that, there's a selection of individual skeletal dysplasias as case reports, which have appeared in the literature. What's important, though, when you look at the first trimester, when we talk about identifying half or more in Sinjalaki's recent population screening of 100,000, we talk about detecting abdominal wall defects, cardiac defects, but next on the list is skeletal. And exactly the point, Prashant, that you made at the very opening of the seminar this evening was we are very good in a sense of identifying that there's a skeletal problem. What we're not so good at is actually classifying it. And in a sense, when you see a fetus with an increased nuchal translucency comes back with normal chromosomes that does not have a cardiac abnormality, the next organ system I think of is the skeleton. It comes next straight after cardiac. So it goes aneuploidy, cardiac, skeletal in a situation where you've got an increased nuchal translucency. Therefore, it becomes important in that group of patients to measure the femur length, to measure the humerus length. And if you find that they are falling outside the first centile in the first trimester, then I'll start progressing and looking at the other long bone shortening. And as we spoke about trio exome sequencing, I know you have in the UK as a rapid service, which you have a turnaround in 2 weeks. In beginning to see in the published literature is offering this service in the first trimester of trio sequencing, exome sequencing in the first trimester. In this case, a series of 16 skeletal anomalies, identifying 10 out of the 16 by exome sequencing. So I see that it's not far around the corner that we will be offering that, particularly in the group who the prior history or previous child. You'll not be waiting for the amnio 17 weeks. You'll be doing your chorion biopsy and exome sequencing because the yield, as I had made mention, is much greater than doing the CMA. So if we run through the talk in terms of the classification of skeletal disorders, I always like showing this because this is a standard textbook of fetal imaging showing the international nomenclature of constitutional disorders of bone, and that's scrolling across about 7 or 8 pages. What you will note as you look at those pages that it's all in font 9. And as soon as you see that, you want to turn to the next page. But unfortunately, when you turn to the next page, you see more of the same. So in a sense, it's a little bit depressing from a prenatal point of view. But the way I think of it is, I guess, is into these 3 groups in the first trimester: the lethal, the non-lethal, and the focal. And we really fall down in the non-lethal. In the focal is where our strength is, as I mentioned, and these can be for upper limbs, lower limbs, long bones, and focal long bone abnormalities. And what I'd like to do is to run through those with you. But let me stop. Let me stop and share with you. In the UK, 100,000 patients screened. How many of these had skeletal dysplasia? And in a sense, this is how I like to look at it. I like to divide it in half. On the first half here, you have 81% that will present with focal anomalies. In the bottom half, you'll have those that present with the skeletal, global skeletal dysplasias. And if you look at those, you can divide them into the lethal and the non-lethal. So when you look at these numbers of 14 and 12 out of a population of 100,000 screened, you're looking at the order for the lethal, maybe 1 in 8,000, for the non-lethal, about 1 in 8,000, or put together 1 in 4,000. So, for a public hospital like the Mercy, where I work, where there's about 5,000 deliveries a year, I might see a skeletal dysplasia once a year. So in a sense, that's what makes it so challenging, is they're rare. And not only they're rare, there's so damn many of them, and there's so many different types. So we said there's Sahar's data is more up to date than mine. This is 480. And in a sense, that's where the challenge lies. I like to include this slide because it's a study that would never get legs passing the ethics committee nowadays, but it's in the study where patients were randomized into two groups of having a 12-week scan or an 18-week scan, nothing other. You had one or the other as your anatomy scan. It was interesting to see that in this population screening study, that 35% of the skeletal anomalies were detected in the first trimester of pregnancy. So if the pressure is on that this is the only anatomy scan and you go the distance in doing a full anatomy scan, I think your detection rates will improve. This is a study that published, I know it's a little bit out of date, but there is an important take-home message from the published BJOG some time back.
Simon, can I interrupt you?
Fairmore is a single center study, a 15-year single center tertiary referral. And this is a very important take-home message that only partial characterization was possible by ultrasound the first trimester as morphological analysis, especially of the limb, thorax, skull, and particularly the digits, because the digits are difficult. And this is what makes it so difficult, particularly when you're looking at wide genomic screening, the limitations that we have in the first trimester. We cannot phenotype it, and therefore there will always be limitations, no matter how good the genetics becomes. And if you look at it for the global skeletal dysplasias, these have the ones that have been described. I'll not go through them, but what I will say is what is most important is seeing an increased nuchal translucency, high drops, or an abnormal ductus venosus waveform. These are three important markers, indirect markers for all three of them. If you see these, then you need to trigger looking at for short and long bones. And you can see in some bowing or fracture first trimester, but these are less often than you will pick up these other markers which have been described for the second trimester. If you want a chart for biometry in the first trimester of pregnancy, this is probably the one that I would use. Other charts more recently have been described. This is one of the first charts looking at 10 to 14 weeks for both femur and for humerus. And if you look at it there, for around a gestation of 13 weeks of gestation, you're looking at the mean around about 8 or 9. But if you get up to their 90th centile, and if you come down to the 5th centile, you're around about 7 millimeters. So just bear that in mind in your routine screening. But for most, you'll find them around just short, at 13 weeks, just short of a centimeter. So if you go into work tomorrow morning, you see in the top left-hand corner, what strikes you here is an increased nuchal translucency. But you also note that the proportion of the size of the limbs to the actual fetal torso is reduced. And if that doesn't strike you, if you routinely go to measure the limb bones, either humerus or measuring the femur, you will recognize that femur is much shorter than it should be. This is the normal length of the femur would be at this stage in gestation, around about 9 millimeters at 13 weeks. And similarly, looking at the radius. So both radius and humerus are below the first centile. And similarly, if we go to the femur, we have a femur measuring 6 millimeters. But when you look at this image, if you magnify the image of the thigh, you actually just simply look at the proportion of long bone that is inside the thigh, and it should be to here. So that's the length of remember, this is a endovaginal scan. That's the length of what a femur should be inside a limb of this size. So this is the size of the shadowing. An important practical point that was asked earlier on was in terms of measuring long bones. You ideally want your long bone to be perpendicular to your beam, and you want to increase your dynamic range so you get the shadowing, so you get a precise measurement. This is probably the best position in measuring, getting accuracy in measuring limbs at any stage during pregnancy. Case number 2, what's the standout again is nuchal edema. But when you come down to look at the femur, you see the femur measures 2.6 millimeters. In a sense, you don't even need to measure because it strikes you. You will see as you're scanning back and forth through the abdomen, there is also an omphalocele. But this is the length here of the thigh, and your length of your bone femur should be approximately so. And similarly, as you look, excuse me for a second. Hello?
Simon, there is
a humming noise. Humming noise is coming.
Okay, thank you. I'll turn off the fan. Maybe it's the fan. Sorry, folks, for that noise interference. It may have been the fan in the background that was causing.
No, still it's moving.
Okay, I'll keep going. Let's go to the next slide. This one a little bit more subtle because you see the nuchal is just above the 95th centile. As you come down here, you see that there's bilateral talipase. And then if you come over to the long bones, you can appreciate both in the lower leg and looking here, the femur, it is shortened. But this may require physical measurement. But if you look here, this is the length here of the thigh, and you expect the femur to be so. And as I say, for most of these subjective, but you go on and measure the femur length and it's below the first centile. Next, there is on to 3D assessment. And for 3D assessment, if you look at here, the upper arm looks normal, but the forearm is shortened. And then you may appreciate that more easily on 3D when compared to 2D assessment. And in here, you've got very gross shortening of both the upper limbs and the lower legs on a 3D reconstruction in features with very significant nucleodema. But for most, I say it's a 2D diagnosis, not 3. So if we go on then to isolated anomalies in the first trimester of pregnancy, just see if I can bring my watch back up. Polydactyly would be probably one of the most common, and there's quite a complex genetics behind polydactyly beyond the scope of this 30-minute talk. But for most polydactyly, they're familial, benign finding, not associated malformation. I know there's a strong association with skeletal, but skeletal are rare, and polydactyly is common as a benign finding or associated with trisomy 13. But if it's otherwise euploid and you see polydactyly, you should raise your index of suspicion with regard to skeletal dysplasias. But for us, for most of the time that we see polydactyly, it's in the setting of seeing the trisomies. And if there's no signs of trisomies in isolated finding, the next step you have to gauge is this extra digit. As you see it flopping off the side of the hand with manual palpation, you see there's no tone. That becomes somewhat relevant in cancelling the patient because these can just be snipped off after delivery. As opposed to this case here, where you can see there are actually 2 phalanges in the extra digit in the fetus with postaxial polydactyly. In the bottom left or middle here, we have an extra digit coming off again with 2 phalanges, but it's free floating. So there can be quite a variation as to how polydactyly may appear. The ones that I worry a little bit more about is where you have a complete digit that almost looks like part of the hand with its own, as fused here, it's a polysyndactyly. So it's not as a separate, isolated, independent digit, but it's actually fused. And anytime I see syndactyly, it increases my index of suspicion with regard to genetic syndromes. We may see from time to time polydactyly that is unilateral. So this hand here has got a normal count. In the first trimester, unlike the second trimester, you're more likely to be able to get all digits in one of you in the first trimester with current transducers. And in this one, you see that there's an extra digit hanging off the side of the hand. This is quite a challenging case, and I wasn't expecting much. But when you went on to examine the rest of the fetus, there was no other major abnormality. But looking at it here, we can see that there was a duplex system on one side here on the 3D with VCI in a reconstruction with a normal kidney on the opposite. And this is here is a 3D rendered image here showing the polydactyly. What surprised me, and this was a chorion biopsy, was a trisomy 13, completely normal face, normal brain, normal heart. But the clues there were the polydactyly and the duplex system. I'll skip this in the interest of time. I will make the point is that comparing transabdominal, where the quality of the image doesn't allow resolution of the digits. I know you could say that this is an old case, but look at the difference when you move to an endovaginal scan in seeing the extra digit as a postaxial polydactyly. Here's the thumb, and then count the digits. So it is so much clearer in a sense, and in fact, our detection rate of polydactyly is much higher at endovaginal scan when compared to transabdominal. So when you look at this, you may find this hard to appreciate at a transabdominal scan of fetus with a normal nasal bone, thin nuchal translucency, but when you go to an endovaginal scan, it stares out at you. You have an extra digit hanging off the side of the hand, and the fetus with polydactyly. So it's much easier to appreciate. And then with manual palpation, with increasing your dynamic range, you can see it's a free-floating digit. What's far of greater concern when you're seeing polydactyly is in the setting of which it's preaxial. As soon as you see preaxial polydactyly, it makes you far more suspicious that you're looking at a genetic syndrome. So you look at the 2 bones here, the phalanges here as part of the thumb, and we see this far less frequently. But once you see this, it enters the possibility of a whole range of genetic syndromes. So you should not treat this in the same way as you do postaxial polydactyly. And then there's polydactyly of the feet, which is always more challenging. So when you look in this case here of a mid-trimester foot showing the extra digit here and compare it to the first trimester. How much more difficult is the first trimester? When you look at the polydactyly in the first trimester, what you're looking for is simply dots, and you're counting the dots across. It's almost impossible for many of these to distinguish between polysyndactyly versus polydactyly. The other clue which may be helpful in the first trimester is by seeing simply that the foot is broad at the level of the digits. If you're not able to distinguish, you should be suspicious. And in this situation here, if you ever see an encephalocele, remember to look at the digits of both hands and feet, because polydactyly of the feet and hands, and this is a fetus with Meckel-Gruber, you can actually see the cystic kidneys here. The kidneys are the most pertinent finding in Meckel-Gruber, the most consistent finding, but this fetus also had an encephalocele, and this is a 3D rendered image of the fetal digits. So I'm saying it's difficult, but it's possible. There's then oligodactyly. When you're looking at oligodactyly here, you can see this fetus here with 3 fingers and a thumb. And this is in the same, more footage here, the same patient at the mid-trimester showing the thumb and then coming across 3 fingers. And this is the rendered image of the same fetus. The Sahara mentioned to me as we were just preparing before we started the seminars, in a scenario like this, where you see a fetus, particularly in the second trimester, who's growth restricted, to remember to consider Cornelia de Lange in these situations where you have oligodactyly. And it may be more severe. This is a fetus here with a thumb and just 2 digits coming across here. So a more severe form of oligodactyly. And here is what's more concerning, because here I can see the thumb. I can't work out whether there are discrete digits or not, because they're syndactyly. And as soon as I see that, I become more suspicious. And this was part of ectrodactyly ectodermal syndrome. And you can see that very abnormal profile with the premaxillary protuberance of a facial clefting. So when you see that in a setting of consider ectrodactyly ectodermal syndrome. And here's another example here coming across to the feet. As you look at here, you can see the cleft in the foot in a first trimester foot. And in the bottom left-hand corner, in the same rendered image in this fetus here, you can see ectrodactyly. And then you come up to the fetal face. And as you come up here in the fetal face, you'll see just here is your facial cleft with a discontinuity of the lip and a defect here in the maxilla in a fetus with ectrodactyly. And again, specifically screening for chromosomal microarray, looking for TP63 mutation. And then moving on from that to the reduction limb defects. And for these, I think our detection rates are increasing in the last decade. Again, from the 100,000 population screen from Sinjlaki's work, 75% of these are identified in the first trimester. So we have overtaken the second trimester in screening for reduction limb defects. And when you look at these, they can range from either an absent limb. So if you come across here, you can just see a rudimentary tissue at the left origin of the left shoulder compared to the other side. So this is the forearm arm, and you can see the individual digits. But when you rotate around the y-axis, you can see that you have a missing forearm. Chorion biopsy was normal, and the patient chose to continue the pregnancy. And this is the same patient here later. And you can see just a rudimentary digit, just 2 tiny digits present are coming off the shoulder in the same fetus at 21 weeks of gestation. Moving down the arm of lesser degree of severity, we have an upper arm here with a humerus on both sides. We have a forearm and a hand on the left-hand side. But if we come back on the humerus on this side, we see we just have a rudimentary forearm. And coming across in a 3D rendered image, this is where 3D helps, because you've got that fluid to tissue ratio that's so great. And from a patient's point of view, they will understand this far more than any other image. So you have an upper forearm with a rudimentary digit at the very end of the forearm. This moving down the arm, so we have a radius and an ulna. But when you look at the end of the radius and the ulna, you see that there's no hand. In contrast, we have a hand with 5 digits on the opposite side. Similarly, in a rendered image showing an arm, forearm, and hand, and then come into the opposite side as we see the forearm, but we have no hand at the end of the forearm. And when you see any of these sort of anomalies, it's important to look to see if there's any evidence of an amniotic band, particularly around the pre-IPT scan or early in the first trimester. You can see these amniotic bands, and when the limb moves like a spider's web, you can see the amniotic band move. They don't always present like that in a small proportion of them, and this is a pre-NIPT scan, at 10 weeks of gestation, you can see the volume of fluid inside the amniotic sac is reduced. It's like a burst balloon. But what you note by speeding up the cine loop is that every time the fetal arms move and the legs move, that the membrane moves. This is the same patient here at 13 weeks gestation, 3 weeks later, and now you can see the syndactyly, oligosyndactyly of the arm here, the hand here. So the fourth and fifth are fused. And then there's 2 other digits. So we're on to radial ray deformity. Radial ray syndrome, I see in a completely different light. So if I see a situation where there's a fixed flexion deformity of the hand, no thumb and no radius, they are the typical findings of radial ray. The ulna may be normal, but not infrequently it is also hypoplastic, or indeed in some cases it's absent. And why do I see it in such a completely different light? Because it's got such a strong association with aneuploidy and genetic syndromes. Unlike the previous anomalies I've showed, for many of these, they are vascular events or amniotic band. For radial ray, this is not the case. In fact, a large population study from 2013, the American Journal of Medical Genetics, of 138 astounding number of cases, that only 13% were truly isolated. So you need to bear that in mind, that to bring in the geneticists early in the piece, and they are very detectable in the first trimester of pregnancy. So here we have a normal appearing humerus. We come down to the radius, which absent radius, we come down to ulna, which is shortened. And here you only see 4 digits with no thumb in sight. And that's the typical appearance. In the same features, you take a 3D with VCI static, come down to the shortened forearm bone, which is an ulna, and then there's just 4 digits. In case number 2, you will also note that there's an omphalocele and that flexion deformity, absent thumbs, and a single forearm bone, which will be the ulna, which may be shortened. So for many of these, again, when you see them, is to look for any evidence of associated malformation. In this case, in the bottom right-hand corner, fixed flexion deformity. As you scroll down to the abdomen, also had an anterior abdominal wall defect. When you see these as well, it's important to check for the rest of the limbs. They may be part of the akinesia syndromes. This is a fixed flexion deformity in a fetus at a pre-NIPT scan at 10 weeks of gestation, and bringing the patient back at 13 weeks of gestation. You can see the arms held out in this fixed position with a fixed flexion deformity on one side. A very rare case, which Sarah made reference to, is the facial femoral syndrome. Only 92 cases of these are reported in the world literature. Important in these to look for associated abnormalities, of which there are many in the fetal face and other organ systems. And you may identify this at a first trimester scan. So this is a fetus at 12 weeks and 4 days of gestation with a thin nuchal translucency. As you scroll across in sagittal, you see nothing of note. And then when you sweep your transducer looking into a transverse section, you see a normal looking femur, as I say, occupying 7/8 of the limb. But when you go to the opposite side, you see a very different appearance to the femur on the other side. So we come down to the bottom right-hand corner to give you more details. The bottom right-hand corner also shows that the fetus has got retronathia. So next, when we see that there's a very abnormal appearance to the femur on this side here, it almost looks bowed, we next move to an endovaginal scan, and we can see the shortened femur. So it can either be shortened or it can be absent, with a normal femur on the opposite side in the setting of retronathia. And if you recall back in the previous slide, retronathia was present in 65% of them, and the femur being hypoplastic in 78% of them, only agenesis in 12%. So you'll see that combination of finding. And I think if I right, Sahar, you said that we don't have any genetic gene mutation identified for this particular anomaly. Going on to endovaginal scan, comparing the two femurs, you can see the difference you get in the image quality at an endovaginal. This almost looks like a mid-trimester femur and thigh, but this is at 12 weeks of gestation. Moving on, just let me check my clock. Continuing on to clubfoot. And I've got to say, I was a little bit surprised in a sense when Sinjalaki's 100,000 patients screened 93 cases of clubfoot, a common abnormality. But what surprised me was the detection rate of only 5% in the first trimester. And I'm not sure whether that's simply that talipase is not evident in the first trimester of pregnancy. or whether it's a situation there's a reluctance to call talipase in the first trimester of pregnancy because there's always that concern of false positives in first trimester, which we all know. Or is it simply that in the population screen that they didn't have an endovaginal scan? Or is it a combination of all three that the detection rate was so low in the population screen? Because we know when we recognize that talipase is possible to identify in the first trimester of pregnancy, but you have to adopt an approach of extreme caution. There's a very nice review of everything and anything you wanted to know about talipase that came out last year. But bear in mind, IRIS has also published in the White Journal a very nice meta-analysis on talipase, bearing in mind that many of these are revised after birth and many of them are more complex and some are more simple. But remember, there is association with aneuploidy. So if we see a convincing talipase in the first trimester of pregnancy, if necessary, repeat an examination to confirm that it's not a positional variant, then it is reasonable to consider in the era of microarray to offer chromosomal microarray. In this case here, in the top right-hand corner, you see a thin nuchal translucency. In the bottom left-hand corner, you see a standout talipase. It's indisputable because it's exactly the same of what it looks like in the mid-trimester, and you can move to 3D to demonstrate that, but I will skip that in the interest of time. Similarly, standout talipase with that tomahawk, almost like the radial ray equivalent, but the digit count, of course, is normal. And we see these for sure in the first trimester of pregnancy. Anytime you see them, of course, you go straight to the brain, but the problem with the first trimester is the corpus callosum is not formed at 12 or 13 weeks of gestation, but you can at least get some detail, but that would be the next organ system I would move to after examining the skeletal system for skeletal dysplasias. And then there's the akinesia syndromes, and for these, it's just a fetus with fixed flexion deformity in unusual position. So this is a fetus in a Buddha position with the legs that simply didn't move. And in fact, the fetus didn't move at all for the entire duration of the scan. There were fixed flexion deformity of the hand, subcutaneous edema, increased nuchal translucency, which are all features described in arthrogryposis multiplex. This was in a fetus at 10 weeks of gestation. And then there's the spinal abnormalities. And for spinal abnormalities, we all know about spina bifida. I won't be covering that, but I will be commenting about Serena Maelia and hemivertebrae. If you look in the 100,000 patients screened, none were picked up in the first trimester of pregnancy. And I think that probably relates to how much detail you put in your protocol of how far do you push it in terms of looking for spinal abnormalities in the first trimester of pregnancy. So if you routinely look at the vertebral bodies, and the way of looking at the spine is to divide it into halves. The centrally, what you're looking for is the blocks, and the blocks of the vertebrae, and the different coronal plane are the transverse processes. If you go to the process of looking at that on 2D and looking for a missing block with the tilt of the spine, you can confirm with 3D. This is at 12 weeks and 4 days showing that tilt in relation to a hemivertebrae. You may also find sacral agenesis. So you look at the base of the spine, you see no ossification and absence. The iliac crests are readily visible at a first trimester scan. Or you may see that there's a tilt in a thoracic spine. If you ever see that, or for most often I should say that you see that, will be in the setting of an omphalocele with a thoracic tilt. But if you see it as an isolated finding, consider hemivertebrae, and once you do that, the next you move to is the limbs and the heart to see whether it's part of vater or vatral. Then there's sacral agenesis. If you see that the torso looks approximately the same size as the fetal head, that'll be one of the other clues, additional clues for sacral agenesis. Not uncommonly, this is seen in insulin-dependent diabetics. I'll finish with the last case. It's a Serena Maelia, which you may pick up in the first trimester of pregnancy. And like these very rare anomalies, there's always very detailed classifications, but you may not see one of these in a lifetime. And then if you look at it, there are very few survivors with Serena Maelia in the world literature. If you look at it, this was one of the survivors, which is the life story documentation of these children. And essentially, many of them are born with no bowel, no rectum, no basically urinary tract, lower urinary tract, and they succumb. And this was one of these miraculous, those who made it through. But we published just very recently in April of this year, a multi-center study of my good friend Waldo Sepulveda and many others, Eran, Andreeva, Ignacio, and George Guedes, and Pilar, across many centers. We looked at all our cases of Serena Maelia, what we noted was that an abdominal cyst was one of the striking findings. And in fact, it may be one of the things that gets you when you're scanning down through the abdomen, you see a big central abdominal cyst, because seeing the fused femurs or fused thighs may be difficult in patients with large BMIs. And you may see two fused feet, but two separate feet. But for many of them, it would be a single foot or no foot. And none of them had associated with chromosomal abnormalities, but they are very rare. And coming across it here, if you look in this case, you have fused lower limbs and you have 2 feet, but they are fused. The legs, you can see just a single lower leg bone on each side. So instead of being 4 bones, there are 2. And in this, I don't know, that's the same case. Bottom left-hand corner and top right-hand corner are the same patient. In a dichorionic twin gestation, the 2 femurs are juxtaposed, and there's a single lower limb with a single foot. So there are different types of cyrenomyelia. So in summary, first trimester, I think probably the take-home message for the first trimester is that for lethal skeletal dysplasias, yes, I think we can pick these up, a significant proportion of them, and we can, with the advancement in genetics, offer NIPD for the select few, which we mentioned, and also offer invasive genetic testing. For the non-lethal, I still think there are many challenges that lie ahead. I guess one of the concerns I have in all of this, and in a sense it's maybe the elephant in the room, is that when patients present with increased nuchal edema and obviously short and long bones, where you know there's a skeletal problem, is many patients choose not to continue the pregnancy. And for those, if they choose to go to termination of pregnancy, you do not have a post-mortem as a final arbiter, unlike the mixed trimester. And that concerns me about the first trimester, in a sense that you don't get a phenotypic description of what the findings were, so you know what you were dealing with, and that becomes important in terms for the patient for subsequent pregnancies. And as Sahar mentioned, that storing DNA in the cases of for termination of pregnancy is fetal tissue in saline sending to the lab for later DNA analysis is a very important take-home message from all of this. What is really promising, though, on the upside of all of this is that if it is possible in the first trimester, as we move closer to routine assessment of femur length and humerus length, I think we will improve and maybe begin to move into the non-lethal. And in the era of exome sequencing and a whole wide genome sequencing, I think exciting times lie ahead. But we need to balance that in the world of VUS and be sensible in how we take things forward in the limited phenotypic description of these skeletal anomalies in the first trimester. I thank you very much for your attention.
Thank you. Thank you, Simon, for some excellent images, excellent collection of the images and phenomenal work which you are doing, and a very crystal clear idea. When tomorrow morning, when you attend your clinic, if you see the first trimester scan and what to see, how to follow them up, and how to look for these skeletal malformations. Moving to the question and answer session, I have a couple of slides which shows the. Yeah, please, Aris.
Can I just answer one administrative question that comes up a lot,
yes.
Which is, can we have a certificate of attendance?
Yes. We
have listened to your requests. We have worked hard and we have made certificates of attendance. So at the end of the webinar, I am assured you will receive an email, not immediately. I think it takes a few hours for them to work out who's been online. And you click a link and then you can download your certificate of attendance. It's the first time we do it, so if it doesn't work perfectly, please bear with us. But this is now going to be the way going forward. Sorry, Prashant, I just wanted to say that.
No problem. Now we have, on a request, we have developed that checklist for the second trimester, which somebody had asked me. So I'm just sharing that slide with you so that you can click that for your information. This is the slide on the entire thing. This is a reference which you have got. 2008 was published, and when you have got these kind of things, so we need a proper kind of program, a checklist, which we have developed 10-point program. You have got that checklist with you, and evaluation with the skeletal mode by 3D and 4D with a VCI A plane in particular, and a 3D evaluation of all possible regions which has been mentioned previously, and suspect the possible type, NGS, panel and array, DNA preservation, and a phytogram. So in nutshell, on one slide, you will have these entire crux of the today's webinar. Now, moving to next question. I'm happy to ask the question by Professor Rabi Chavi to all of us, particularly to Professor Dr. Sarah Manor. What Professor Rabi Chavi wants to ask is, does cell-free fetal DNA shows all three conditions differentiation, mutation like AC, TD, and Hello?
Yes. Yeah, we can hear you.
Okay. Can this tells the difference between all three conditions, and can you diagnose, can you spot the conditions and whether you have done CVS or amniocentesis or you have done NIPT?
So for NIPT for FGFR3 gene is very good. Achondroplasia is caused by just 2 mutations. So if you've got one of those 2 mutations, it's achondroplasia. The thanatophoric dysplasia, you will have a lethal skeletal dysplasia and a mutation in FGFR3. There's more mutations to look for, but there is a limited number. So you have a good idea. And then hypochondroplasia, there are many, many mutations. So it's not so good. Not so good for hypochondroplasia.
You cannot differentiate in a cell-free fetal DNA in the first trimester or even the second trimester for all three differentiations.
You can, because achondroplasia is just one of 2 mutations, so you know it's achondroplasia. And the thanatophoric mutations are well known, so you can differentiate between thanatophoric and achondroplasia. Yes.
Yes.
You might miss hypochondroplasia.
Okay. Thank you. Thank you. I think, Professor Chavi, the question which you ask is answered. Now, what is the role of MRI in skeletal dysplasia?
Are you asking me? Or Aris?
Silence.
All three. All three.
Aris, you go.
Silence.
Not good. It's not any good in the first trimester.
MRI, you got away with that one. MRI is not brilliant at looking at bones. I mean, ideally, what you would like to do is to have a CT scan, and postnatally, certainly after, if the parents, for example, decline a post-mortem, they may actually accept just a simple X-ray, but they may even accept a CT scan. And doing fine slice CT is really brilliant for looking at the skeleton in great amount of detail. But I'm not aware of any important studies or large studies that evaluated MRI for skeletal dysplasias. I'm almost certainly wrong. Someone will have done it, but it's not something that we use in our clinical practice.
Some countries are routinely doing CT scans in pregnancy to look for if they think it's skeletal dysplasia. I think Japan is one of them. The delegates can correct me. I think it is offered in some countries. And then MRI is being offered in the UK as a research tool. At Aris, we can get it done at Guy's Hospital, are really interested in looking at that. So it's not enormously helpful yet, but it might become so. So that's an evolving mode of looking as well.
Aris, next question is for you from Johan from Indonesia. Wants to ask, do I need to measure humerus tibia radius to rule out skeletal dysplasia?
So in routine ultrasound, so during a routine scan, the recommendation is to measure the femur and the humerus. And if you've measured those and you've looked at the rest of the skeleton, we don't routinely measure in most guidelines. Does not ask for routine measurement of the other bones.
Simon, the next question is for you. This from Lata from United Kingdom. Short femur. Hold on, where that question has gone. Short femur. Can it be the first manifestation for IUGR? If yes, what is the pathophysiology?
Not my experience in terms of first trimester growth restriction. Have we used femur length, unlike the third trimester in pregnancy? For us, the skeletal dysplasias are really the ones where just strikingly, obviously, lay down Mézières that there's a skeletal problem. And for the ones where we see an increased nuchal translucency, it becomes important to measure femur length. But not in my experience have I seen that in a setting where I have an abdominal circumference that's below the 5th centile and everything else is appropriately grown and the femur takes me there. No, I don't have that experience. I don't know if the others want to pass comment, but no, it's still quite different to the third trimestral pregnancy, the point that Iris makes about doing uterine artery Dopplers, but I have no experience of that in the first trimester.
Next question is from Egypt. Amira Aziz wants to ask, can IUGR femur only be short without abdominal circumference?
Oh, sorry. This
so
one.
The answer. So the answer is yes, because what happens in IUGR is you don't start with IUGR where all biometric variables are below a certain measurement. So the classic way of thinking about IUGR is that the AC is the first biometric variable to fall below the 5th centile, followed by the femur, followed by the head circumference, because you have a degree of brain sparing. But actually what we showed in that study that I showed you during my talk is that in very severe early onset growth restriction, sometimes the first presentation is a short femur, and we're talking about the sort of growth restriction that you see at 22, 23 weeks. The AC will also usually be already below the 50th centile, but may well still be within the normal range. So they may actually present as a query short femur isolated because the AC is still within the normal range. Femur length is below the 5th or 3rd centile, as is the humerus. And the clue is really in the Dopplers. So what you're looking for is evidence of early onset uteroplacental insufficiency. And then when you follow these babies up, of course, as they develop IUGR, then other features start coming in, such as a reduction in the AC and other Doppler abnormalities and maternal preeclampsia very frequently as well.
Thank you, Aris. Now there is one more question from Romania. Madalina wants to ask, thank you for the presentation. At a 32-week pregnancy with an isolated short femur at 5th centile, what should I do? Question goes to Aris, of course.
It's a summary of the whole program in some sense. Yes. So you have an isolated short femur, ensure you've done a careful skeletal survey, ensure that everything else looks normal. Do your Dopplers. If everything is normal, the bones are straight, they're normally mineralized. This is bilateral, it's symmetrical. You see no other features in a very detailed scan, including hands and feet and scapulars and all the rest of it. Then we're talking about an isolated shortness of the long bones. It may well be constitutional. Look at the parents. It may well be that group of unexplained shortening of the limbs. And of course, there can be a skeletal dysplasia. So Saha showed the SHOX gene abnormalities, for example, which are relatively common. But at the end of the day, what your counseling will say something like, the bones of the baby are on the short side. At this stage, what I have is a snapshot in time. So the first thing we need to do is to monitor the growth of the limbs going forward and see how they develop. If they continue to grow on the 5th percentile, it is likely that it's just normal for this baby. In the meantime, what we need to do is consider any further testing that we want to do in terms of non-invasive or invasive prenatal testing for a skeletal condition, because we can't exclude a skeletal condition, but frequently we may defer that decision to later on in the pregnancy once we've seen that this is definitely pathological rather than just physiological. So sorry to try and compress that all in a single sentence, but it's not easy, and Simon has his hand up.
I think if I can just go back to the point where you trigger, suspicion, and you go on to do your uterine artery Dopplers and consider growth restriction, then consider skeletal before you pack your bags and everybody goes home happy. If we can go to the point where you actually, what triggers you to go to the next step, and is it which chart, number one, and what centile, number two? because it's the point that Prashant made earlier on, and I think it's a very important point. And you may turn around and say to me, it's not one point, Simon, it's actually a serial scans that I want to know. But you make a point, you draw a line in the sand where you say, I want to bring you back for another scan. So what is the chart and what is the centile that you think people listening tonight, Iris, should start with?
So in our unit, we will use the intergrowth charts, which are based on healthy populations. So we like to compare women to what should be, what the fetal growth should be. And we use 2 standard deviations in practice. You can, of course, use a higher centile, which will increase your detection rate, but will also increase your screen positive rate. So always remember that.
But this is what
how do you reference, Prashant, if I can just come back very quickly to Iris, and what point do you reference that individual charting versus the other biometry, the abdominal circumference and head circumference? When do you weigh them in?
Sorry, I don't quite follow your question, Simon. What do you mean bring them in? So you would do all the biometry at the same time, right?
Yeah, it's just that I treat a femur that's far different to the abdominal circumference and the head circumference more seriously, I guess.
No, absolutely. So I think you're absolutely right that you look at the, if the baby is, if all the measurements are on the smaller side, then an SGA type of growth restriction picture is more likely than if you had, as the example that Saha showed, where you had a very small femur and a large head. And remember that in a lot of skeletal displays, this is a degree of macrocephaly. So of course, these will always be different. Now, we could talk a whole other program on different charts that one might want to use and what cutoffs might want to use in different settings. The point that we make in terms of our in terms of charting fetal growth is that you have we have international standards. We use international standards because we believe that international standards best represent our international clients from all over the world. And once you go to 2 standard deviations, the difference at the 2 standard deviation level tends to be relatively small between different settings.
This is a chart which I was telling that this is a clinically relevant chart we have developed. This is the 1st centile, 5th centile, because every chart will give you 5th centile, 50th and 90th, 90 or 95th centile. But we specifically added 1 centile. So any length grows below this, or any deviation happens below this 1st centile. So that's what I was trying to tell you, that these are all clinically relevant charts which we have started using, and we have developed these charts specifically for short long bones as well as the head circumference. If the head circumference is small, to diagnose microcephaly, these are the charts which are going to be really helpful. Now moving to next question of ours. Let me Aris, do you have any specific questions to ask?
I think there was just, I don't know if Saha's still online or if she's had to go, but there was Saha, there was a couple of questions about specifically regarding, let me just find them. I'm ever so sorry. So Els from the Netherlands was asking about how an ossification center can be differentiated from achondrodysplasia punctata. And, I think, I don't know if you had any thoughts on that.
Yeah, so the chondrodysplasia punctatus is a highly heterogeneous group. There's many causes of, there are many different types of chondrodysplasia punctata, and the clue is to find stippling, which is ossification of the epiphyses. Usually most of the epiphyses are not ossified in the fetus. So if you see tiny areas of ossification within the epiphysis, particularly in the tarsal bones, the carpal bones, at the spine, it puts that baby into the chondrodysplasia punctata group. And there's a whole, I could give a whole talk about chondrodysplasia punctata because there are many different causes with different prognoses and different etiology. So I often ask Aris to look for stippling. I think it's you can't really see it before the third trimester, and it can be very difficult to see. But if you see it, it points to a specific group of conditions.
And then thank you, Saha. And then the other question that's been quite recurrent is we've talked about paternal age, and I guess this will be a similar answer, that things lie on a continuum. But people are asking, what paternal age would you start being worried about? Is there a kind of cutoff where you say, look, beyond this, really the risks start going higher?
Yeah, so really, I suppose it's a bit like Downs. The risk starts to go up at, say, 35, but it's still very, very low, and it slowly creeps up. But because men are still fertile well into their 70s, like Charlie Chaplin, for example, it continues to go up. So the older the father, the higher the risk. It's still a low risk, but if you have an elderly father or partner, you need to think of these conditions. So yeah, it's on a continuum. You're right.
And I guess it's like most of what we've been talking about really today is fishing for clues. You know, you see something and you're trying to get clues through our ultrasound, but you're also trying to get clues through the history. And this is just one of those things that might give you a clue.
Yeah, that's right.
Can I ask you to say a question for Sahar? I mean, we talk about our concerns about whole genomes, wide genome sequencing, and even for exome sequencing, about the concerns about VUS, variations of unknown significance. Yeah. But when you consider the benefits for skeletal are so great compared to any other organ system, we are getting to the point where we have an anomaly, an organ system where the genetics were reaching 85% yield. I mean, that's extraordinary. Should that not be balanced against the low percentage of VUS, and should that not be something of a lesser concern, VUS, in the setting of skeletal dysplasias?
So the skeletal dysplasia group are probably the best group to do the fetal exome in. You have the highest benefit with the lowest VUS rate, I think, but it does help enormously to have an accurate phenotype, to look at the presentation, particularly if you've got x-rays, if you can get the x-rays, because you can correlate the finding and you'll make less mistakes. So it's an enormously helpful tool, and it is one of the few inclusion criteria for rapid fetal exomes. I still have seen VUS in this group, so you still need to read the report really carefully before giving the result and interpret it in the context of the presentation of the baby. So it is an issue, particularly because there are so many genes the skeletal dysplasias that you can still get it wrong. The more genes you look at, the more VUSs you will find. And then there are some scenarios where it's much, much simpler just to do a single gene, like the thanatophoric achondroplasia. You know, you have a high suspicion index for that, so it's safer and easier to do those. But yes, definitely, it's the way we're going, and it's enormously helpful.
I guess where I'm going with the question is since it's in a sense so good, the positive predictive value is so good, and in the first trimester, why don't we just throw exome sequencing straight after chorion biopsy when we've got a collection of long bones that fall below the first centile with no prior history and nothing more? I
think we're going that way, Simon. I think that'll happen. And let me just warn you, though, if you do it for your limb defects, apart from the radial ray aplasias, which are very genetic, the other limb defects, you will have a very, very low hit rate.
For the focal limb defects, yeah.
Yeah.
You know, I was mainly, that question was more directed toward the global skeletal dysplasias. Yeah. Is that, you know, since the positive predictive value is so good, in the absence of phenotyping in the first semester, which is the real weakness, and the excellent throw exomes after chorion biopsy, and as you say, that's probably the way we're going to go. Accepting VUS.
They are still very expensive. So, you know, in a lethal skeletal dysplasia, we would wait, because in most cases, either the baby's going to they'll either opt for a termination of pregnancy or it will be an IUD. So we will often wait until we have the x-rays in that situation, because it's not going to change the management during pregnancy, and the interpretation of the exome is much easier once you have the x-rays.
I think I'll get killed by a radiologist if I don't say something towards MRI and skeletal dysplasias, but I think they do play a role with regard to the assessment of fetal lung volume, and with the constricted chest, I think for assessment of the fetal brain with skeletal dysplasias, and they can pick up minor fusions and appearances of long bones that we don't see in ultrasound. But I think, yeah, there are enthusiasts for it in the world, but I wouldn't say it's routine.
They won't.
It's not routine, but CT is increasingly being used, especially as a low dose. CT regimes can be quite helpful. Certainly, you wouldn't use it lightly, but if it's going to make the difference between clinically important difference in terms of the diagnosis, then may well be helpful.
I think ultrasound is more decisive in taking the decisions of strategic decisions rather than MRI. MRI will add probably few things, which if you can't access certain or fetal organs, but still the lethality, which is more defined by ultrasound than MRI.
I just shared briefly the slides, and I hope that people were able to get that panel app. But I suspect that if you put Genomics panel app into Google, you will be able to find it and then navigate from there to skeletal dysplasias. The other two things that were on those slides very briefly, we have to thank GE, our sponsor, who allows to make sure that these webinars are available freely online. And can I just remind everyone that in a week, so on the 20th of December, we've got a really brilliant program coming up. I'm not going to tell you what's in it. It's a bit of a surprise, but I can assure you, you will have a great time. We've got Simon there, the legend that is John Hobbins, and Ahmed Bashat, who will join us for a festive special to celebrate the end of 2020. And I think we're all looking forward to seeing the back of 2020 and hopefully we'll go into 2021. I think, Prashant, we could probably end it there if you agree. We have lots more questions, but we've been online for 2.5 hours. I'm in the hospital. I have to go downstairs and finish a few jobs as well. So I just wanted to thank everyone and maybe give Prashant the last few words.
Yeah,
and thank you for hosting today, Prashant.
It's my pleasure. Always my pleasure. But this is the, I think, can you see the screen where you can see the Dysplasia version 2.34?
Yeah.
Can you see that? Yeah.
Perfectly
so this is and this is the downloaded it's downloaded version. You can always download those versions, and I think you will be able to download the version what you are, Dr. Sarah Manor, they are doing there, and what kind of genetic evaluations which they are following. Again, thank you very much. Thank you very much, Professor Saha. And again, thank you, Simon, and thank you, Aris. Of course, I'm thanking GE for wholehearted support to carry out all the webinars across on the Scan Academy platform, and hope you must have enjoyed, and also hope that you will continue enjoying the Academic Fest, which is given, which reaches you by Scan Academy platform. Again, thank you very much.
Thank you very much indeed. Thank you.
Thanks, Saha. Bye.
Bye.
So do you want me to take over? You don't have to play the video right to the end if it's just saying goodbyes and things.
Okay, so we are live now.
Okay. Thanks so much, everybody, for staying with us through this wonderful webinar. And we have a few more questions. So, guys, I know it's been a long webinar. You're very welcome to go. But we have some more questions here online, and with our faculty here, also joined by Helen. Oh, she's gone again. Helen Feltovich, who happened to be online, who I saw. I've also asked Phyllis. Phyllis, if you're still listening, I sent you the link by email if you want to join us online. Oh, there she is. Hi, Phyllis. How wonderful of you to join. So, listen, guys, we've had lots of questions. I'm going to start pretty randomly. And one of the questions was from one of our delegates asking, the fetus has achondroplasia, the mother does not have achondroplasia. Would you be happy to support a vaginal birth in these cases? And maybe I throw that question to you, Jose. Is vaginal delivery contraindicated in achondroplasia?
Should I answer in Spanish?
I think you can answer in English if you like. It was an English question.
Okay. Yes, I would feel comfortable doing that or recommending that, depending on if the cranial and the biparietal diameter is not too big. Sometimes you can also have hydrocephalus, and with a big biparietal diameter. So I would, in this case, I would not recommend that. But in every other case, should be no problem in doing a vaginal delivery.
Fantastic. No, I tend to agree with you, Jose. I think, as with many skeletal dysplasias, there is a risk of macrocephaly. If the head size is normal, then there's no reason not to try for a vaginal birth. But it's different if the mother has achondroplasia. If there's maternal achondroplasia, then you have pelvic contractures. And although there are some cases in the literature of vaginal birth, most of them will deliver by cesarean section. I have another question on the face. Can we look at the face? Is there an objective way to measure the angles of the face to say a face is flat or not? Daniel, what do you do in your practice?
In my practice, I take a subjective look, but maybe an objective way should be the frontomaxillary facial angle described by Kipros School that they use for flat face in Down syndrome. There are another angles in the face reported by Palladini, but they are more referred to micrognathia. But really, I take a look at the relationship between the frontal bone and the nose, and we speak about frontal bossing when the frontal is in front of the line of the nose. I almost all times I look at it subjectively, but those are the angles. The most recommended angle should be the frontomaxillary facial angle, the FMF angle.
Helen, you're on mute, my love.
I do same. I think it's generally more of a, oops, sorry. I wasn't planning to do this, so I'm in my kitchen.
It's okay. It's a friendly
I think I generally gestalt it, but I also calculate the angle. And in fact, what Dr. Cafici was just talking about, I can share with you if you'd like. It's a paper by Weikert et al. From 4 years ago.
Yes,
do you want to see?
Yes, please.
Here, I'll share my screen. Can you see?
Yeah.
Yes, beautifully.
So here is the reference, and this describes the angle. And as Danielle said, this was designed for, or this was looked at in Down syndrome fetuses. And you can see the one on the left. This is an example of a fetus with Down syndrome, and this is a normal. But it's also just useful to look for the flatness of the facial profile and mid-face hypoplasia. Just what I have to say.
By the way, for the audience, I picked up Helen and Phyllis because they posted some questions on the webinar. So always be careful when you post questions, because you might get an email back saying, please jump on the speaker link, given that you're an expert, we want you here. So welcome, Helen. Helen, who's an expert in fetal medicine near Salt Lake City, in Park City, and Phyllis, who's an expert radiologist from Canada. Phyllis, welcome today. Phyllis, we had a chat already in the questions about which percentile you should use to determine whether a short bone merits investigation. And of course, you could use the fifth centile, then you would investigate more fetuses, or the third or the first. What do you do in your practice? What's the balance that we have to strike?
I think for our practice, the balance, unfortunately, is not where I'd like to strike it. We do a thorough bone investigation when we fall below the fifth or the -2 standard deviation percentile. These are invariably go nowhere. I think that taking a full constitutional and family height pedigree is incredibly important. I think we end up obligated to do a full bone survey or a detailed anatomy to go beyond the bones. And if we're lucky, and we're progressively lucky in my province in Ontario, as we have joined imaging systems, so even if a woman hasn't started her pregnancy with us, we're often lucky enough to look at the growth pattern, which will be the single most important, I think, finding for bones that are on the questionable part. As Dr. Mager referred, when it's obvious, it's obvious. So this really is for those borderline between the second and fourth percentiles. So you want to make sure it's not a fetal growth retardation, it's not an aneuploidy. And if you can look back to the growth charts or have the woman bring her prior scans in or go forward and look at it, I think that's very helpful.
Thank you, Phyllis. That's really helpful. Jose, I go to you, and I will ask in Spanish. Dr. Guerrero pregunta, ¿en cuánto tiempo se debe reevaluar la medición de huesos largos cuando se ven cortos? Me imagino que empieza en 20 semanas, están cortos. ¿En cuántas semanas vas a hacer una reevaluación?
Bueno, habitualmente lo que hacemos es una reevaluación a las 4 semanas, comenzando en ese periodo. Esto es importante porque hemos tenido casos de, por ejemplo, que se mencionó acondroplasia, y hemos tenido en seguimiento el papá acondroplásico y con un bebé acondroplásico y un nuevo embarazo. Y hicimos el seguimiento desde muy temprano en la edad gestacional. Vimos que hasta la semana 22 de gestación no había ningún tipo de acortamiento a nivel de huesos largos. Y a partir de ese momento comenzó a retrasarse progresivamente la longitud femoral, la longitud humeral, y pudimos establecer el diagnóstico de un nuevo caso de acondroplasia en esta pareja. Pero el seguimiento lo venimos haciendo cada 4 semanas.
Fantastic. Thank you. I will just very briefly say that the question was isolated short, long limbs at 20 weeks. You know, you've done a bunch of tests. When would you reevaluate that? And Jose was saying probably 4 weeks is a reasonable thing, to leave a little bit of time to see how the bones grow in order to see whether they're growing along the percentile charts or whether they're dropping further behind, suggesting some skeletal dysplasia. And I think we would do something very similar, actually, about 4 weeks or so, depending also on the severity of the shortness. I will go back to Phyllis. I have a really good question from a couple of people which say, well, you've talked about all these different differential diagnoses, But actually, in the end, it doesn't matter on ultrasound. All you want to know is this a lethal skeletal dysplasia, or is it not a lethal skeletal dysplasia? And in the end, whether it's this or that is not so important, and you will find out in the end. What are the markers that you use in your practice to decide whether you're counseling someone towards a lethal abnormality, a lethal skeletal abnormality, or a non-lethal skeletal dysplasia? And do you agree with the sentiment?
I do. I was going to start off by saying that's really, to me, intrapartum, the single most important question that we can help the families with. We can make an accurate diagnosis using ultrasound parameters in isolation, anywhere from 90 to 100%, depending on the literature that you read or the experience that you have. I have been wrong, and as we know, even a thanatophoric dysplasia may survive for a few weeks, but in the greater majority, I think that we have to look at the multiple signs that we have. And so we would look at the chest circumference, and there are charts available for that. We'd look at the heart to chest ratios, and again, there are charts for that. We would look at the sagittal dimension and see visually if the chest is short, if the heart's occupying most of it. I really enjoy looking at the coronal view, where you see a sort of very tight chest that flares out over the protuberant abdomen, the so-called bell sign chest. And I would also, we very much look at the rib lengths to see if they encircle 70 to 80% of the thorax. And we're also looking at the quality of the ribs and the bones at the same time. Short trunk length is the other one that you can do. I think that's incredibly difficult to do. But occasionally you can appreciate that the trunk length is relatively short, and if there's platyspondyly that or very, very narrow vertebral bodies where the disc space is larger than the height of the vertebral body. I don't think I would recommend diagnosing a lethal skeletal dysplasia if only one of those signs was present. You really should have the majority present. I think somebody brought up the role of MR for this. I do think ultrasound probably overall, especially with 3D, really in the question of lethality and pulmonary hypoplasia specifically would have very little to add.
Thank you, Phyllis. Danielle, 32 weeks, isolated short femur, third centile, second centile. A previous risk for Down syndrome was a low risk. Do I need to worry about Down syndrome? Is an isolated short femur a useful marker for Down syndrome? Or is the likelihood ratio low enough for me to ignore that question?
English?
Whatever you prefer. English is good. It's an English question.
Okay. I don't think so. If I have a low risk in the first trimester screening, if the only marker I have is the short femur, I rather think before in IUCR or fetal growth restriction. I will do uterine Doppler or cerebral umbilical relationship. But it's not my first problem thinking about Down syndrome. Is the first trimester risk is low, and if the patient has the short femur as an isolated marker. I don't know if you friends.
Helen, I don't know what.
I agree.
What do you think? A little more medical legally aware in the USA, maybe. In the UK, we would do the same. Isolated femur, the likelihood ratio is 1.2, which is essentially no change in risk. And if everything else looks normal, we don't think about Downs particularly. Obviously, if we do anamnia, we would do a PCR for Downs as well. if we did it for another reason. But, it's not a big discussion point. But I don't know in the US if there's a different take on this.
Well, I can't speak for the entire US, obviously, but in my area, exactly the same. So if I saw this finding, I would look carefully at all the other structures, right? Make sure that I didn't have something like an AV canal defect or something, which would, markedly increase the likelihood of that diagnosis. But then I do exactly as you, Aris. I say the likelihood ratio is 1.2 for this finding, and it's unclear what that means in the third trimester. These ratios were really developed in the second trimester. And I always offer, I offer every patient an amniocentesis, actually, every time, because it's a choice, right? But I think the benefit of that in the third trimester is relatively low. Sometimes if someone is very, very worried after counseling that the risk is very low, I wouldn't have a patient return for that finding, for instance, assuming, as Daniel said, all the other, everything else is normal. I'm not worried about growth restriction or anything like that. I probably wouldn't even have her return, maybe in 4 weeks. Probably not. But, cell-free DNA screening is so easy and simple and fast. And so many of my patients, when faced with this scenario, because it's a common scenario, right? We all see it. And we all check out the parents too. Like I always look at the parents' legs, right? But cell-free DNA is just so easy and non-invasive. And I would say probably half of my patients who have not previously had this screening in pregnancy will accept it for that finding in the third trimester. But many people already come in and they've had screening, in which case, same. Seems like South America, North America, and Europe, we're all doing the same thing.
Fantastic, thank you. Listen, I'm just going to, I had one question about the website that Saha mentioned in her talk. And I never remember any links. So all I would do is go to Google and I would put Genomics England, because that's what she was talking about, and skeletal panel, and it'll be there. So there it is, skeletal dysplasia, genomics panel. So it will tell you what panel is in there at the moment. There's the version that you can download, and that's a panel that we undertake, the genetic panel that we undertake for skeletal dysplasias. It gets reviewed on a regular basis, so it's useful to go online rather than to print off a version, because it'll be out of date by next month probably. That was just a very quick one. Listen, we still have 900 people online, despite the length of time. So I'm going to carry on with questions. Helen, Phyllis, I dragged you into this. If you've got to go, please feel free. Don't feel that you have to stay. Jose, I have a question here about the foot to femur ratio. We talked about the angle in the femur as a useful predictor of achondroplasia. So in the third trimester, if you have short, long bones, the principal differential diagnosis you want to know, is this SGA or is this achondroplasia? And that angle seems to be quite differentially expressed in the two conditions. What about this question of foot to femur ratio? Because to me, I've always found that the foot to femur ratio is largely maintained in SGA and achondroplasia, and therefore I never found it a very useful marker, but I don't know if you have a different take.
Yeah, I think it's a very good question, because when you have a skeletal dysplasia, you will maintain the length of the feet, and the femur will be shorter. So usually the ratio is 1:1. So, and if you have a short femur, you will have a relationship that is not normal. So I think it may help for some types of dysplasia. So we use to measure in every skeletal dysplasia the length of the feet.
Thank you. Helen, how much is a cell-free DNA test in the USA?
Well, it depends on insurance coverage. So for an increasing number of patients, actually even low risk, it's covered. Insurance covers it. Or it's for a minimal charge, maybe $25 or $35. For many of the companies to pay straight out of pocket, it's like $2,500, very, very expensive. But there's one company that, in my clinic anyway, we work with many companies depending on which insurance coverage a patient has. But if it isn't covered, one company, the maximum out-of-pocket cost is $199. So often patients will choose to do that.
It's really fascinating to me, this differential between countries, because Marcela has written here, the only situation with cell-free DNA in Mexico, in Tijuana, is about $800 for a test out of pocket. In the UK, the out-of-pocket, you can get it for £280, which is about $350. And the UK is not a cheap country, I can assure you. So it always fascinates me how the same product can have such a wide variation in cost in different countries.
In Argentina,
it's really wrong, actually.
Yeah. Jose, you were saying?
In Argentina, it's about $600.
Also about $600. Yeah, that's closer probably.
That's why. So I want to rescue the babygram or the fetogram for the lethal skeletal dysplasias, because many people from Latin America is hearing us, and when you don't have the opportunity to do some exome sequencing or in NIPT in some cases, and it's you're dealing with a lethal skeletal dysplasia, it's good to remember that you should make a babygram that is a plain radiography when the baby is born, and not only that, but also radiography of the both arms and both legs, so you can compare. Because if you only do the babygram, the thick body needs a dose of radiation, and the limbs a less dose of radiation. So otherwise, you won't see very well the bones. So I want to rescue in this sequencing era. I want to rescue this figure of the babygram.
I agree with you. I think it's a very useful test. Ideally, of course, you would have exome sequencing and a full post-mortem with bone biopsies and all the rest of it. But a lot of parents will decline a post-mortem. But almost all parents you can convince to get just a plain X-ray of the baby. It can be really very helpful. If you can go one more step and get a CT of the baby, you will be amazed at the clarity, and you can really get a whole skeleton of the baby in 3 dimensions on CT, which is extremely helpful if there is any question around the diagnosis. Well, guys, we have exhausted the questions, which is a surprise to me. Daniel, do you want to put any closing remarks?
No, just thank you again. It was a beautiful presentations. I enjoyed them a lot again. And it was great to share with you, with Jose, and now with Helen again. And Phyllis, nice to meet you. And hope you see very soon. Y gracias a toda la gente de Latinoamérica que a través de Diagnus, de Saúm y de Flaus y de todas nuestras visitas por el continente nos apoyaron hoy. Gracias, Aris.
Gracias a todos. Bye, Phyllis. Bye, Helen. And you're on the hook now for the next one.
Bye-bye.
Thank you, Ari.